2, 1. Please start, ma'am. We are live.
Namaskar and good evening, everyone. I welcome you all for today's webinar on management of early lung and breast cancer. With immense pleasure, I would like to invite Dr. Nitish Garg, who is Assistant Professor, Medical Oncology at American Oncology Institute, Dayanand Medical College and Hospital, Ludhiana, for the welcome and introductory note and to set the ball rolling. Over to you, sir.
Thank you, madam. And so I welcome everyone to this academic feast about management of early breast cancer and early lung cancer. So in the month of October, we celebrate it as a breast cancer awareness month. So it will be not talking about breast cancer first and talking about lung. So I thought keep 19th as a date for breast cancer talk, and then talk on a lung cancer. So basically the early breast or the resectable breast, we tend to see that there are newer changes which are happening. We tend to offer our patients something called recurrence scores testing, and along with that, a neoadjuvant CDK4/6 inhibitors in hormone positive early breast cancer are paving their way into the stream and declining the use of chemotherapy, though it is very early. It is a very early stage for them to come. So we will be discussing about all these things starting today till 9 o'clock. So I would like to invite my first speaker, my dear friend, Dr. Ashwin Philip, sir. So sir is HOD and associate professor at CMC Ludhiana. So I would like to invite sir for his talk on biomarkers in breast cancer. So over to you, sir.
Yeah, Nitish, thank you. Thank you so much for the invite. And initially, I did freak out yesterday evening when I saw your slides. I thought it is unfair to give me a slide like that, but I'll try to do justice to what I can. And where is, yeah. So the topic of discussion today is going to be on biomarkers in breast cancer. And is the slide visible?
Yes, sir. Yes. Sir.
So I'm going to talk a bit about it. I'm not a pathologist, neither am I a molecular oncologist. I'm a clinician, and I'll look at it from a clinical point of view. And a lot of things happen in today's world. There's a lot of discussion about gene profiling of all cancers and should we do it or not in Indian context. So I'll try to take it forward from a physician's point of view and what is relevant in today's practice, what we do in clinical practice. So the important thing is that we've gone from an era. Yesterday only we were discussing in the tumor board. We were seeing an old case in treatment in I think 1990, and that patient, irrespective of the hormonal status, was getting tamoxifen. So at that point of time, the thought process was everybody should get tamoxifen. But the more we understood the molecular patterns of the diseases, we have moved ahead so much, and so much so that we don't give chemotherapy for majority of the patients, even in metastatic disease. Ideally, when we look at sequencing, there are many parts of it. You can do NGS looking at the DNA. You can sequence the RNA also by RNA sequencing, which can also be done via NGS. You can look at the protein expressions and looking at the IHC to see what are the protein that you express. Definitely, you also have the option of looking at the germline mutation that the patients carry forward. So you have an array of molecular tests to pick up and choose, and depending upon what your clinical conditions and your needs are, is how you take your treatment forward. Now, issue is always a tissue. The pathologist will want a lot of tissue. Breast, luckily, we don't need too much when it comes to lung or others unknown primaries is where you need a lot of tissue. So we would always want to get a tissue block. In reality, the problem with especially metastatic diseases is that you may not get huge chunks of tissue, which then may be a bit compromising in your reports. Now, what do you do when you don't have tissue is the era of doing a liquid biopsy. The more we understand this concept of the tumor shedding DNA into the circulation, and you're able to isolate those circulating DNAs and see if you have mutations in there. Well approved in lung cancer to a certain extent in colon cancer, but now we're trying to expand this entire cohort into other cancers as well. So why is it important to profile your tumor cells? And the question that is asked here is that why is it important to profile in advanced cancer? I say the importance is now gone beyond advanced cancer, because today we look at early stage breast cancer, and you look at profiling and you look at this multiple gene assays, which you look at oncotypes, Canasis, MammaPrint, and all those things. Basically, looking at the genetic signature of your tumor cells and deciding how giving you a prediction of how these tumors are going to work. So ultimately, we are going to an era where everything will be sequenced in years to come. So we'll discuss about that. And the basic thing in breast cancer is the fact that you have 3 subtypes, which we all know: the triple negative, which is the most aggressive and the most difficult to treat. You have the hormone positive, which have the better outcomes and treatment outcomes are good. And then you have the HER2 positive, for which you have to use targeted therapy. Now, traditionally, we used to think that if you look at the pioneering work by Soli et al., which looked at the molecular basis of breast cancer, they would say that breast cancer would be 4 types: a luminal A, which would be the best subset with a high hormone expression, low Ki67, low proliferative indexes; a luminal B, having lesser hormone expression and a higher Ki67. Basal type would roughly correspond to a triple negative subtype, and the HER2 enriched subtype. But the more we go into the depth of these tumor cells, we understand that there are much more things. There can be mutations that add on to all these things, like your cell cycle can be regulated. You may have overexpression of your expressions of your some signaling pathways. Even in the triple negative subtype, you're talking about different subtypes because they themselves are a heterogeneous group of disease by itself. Now, we all know that in a metastatic disease, clonal evolution takes place, added mutations come into the picture, and breast cancer is no different from other cancers. The many of metastatic diseases, and as the tumor mutates, you get additional mutations, and that is all the more common in triple negative breast cancer. And then you realize in triple negative breast cancer is the fact that they would be associated with the BRCA genes, and you may have mutations in the hormone recombination mechanism that helps you to recover your DNA damage. So all these things add to the tumor mutational burden, and these things are now showing you the probability that your tumors could respond to immune checkpoint inhibitors, which are coming into a big way in every cancer right now. Now, like I said, traditionally you do biomarkers. You would look at the triple negative endocrine hormone positive breast cancers or the HER2 positive breast cancers. But now we look into we just don't say this. We look into the fact that we don't assume that these biomarkers are static. We assume that there may be pathways inside these biomarkers which then make them more active, inactive, or subtable, favorable in the subgroups as well. So if you look at the triple negative, you know that chemotherapy plays a very big role. You have single agent chemotherapy, then you have the role of carboplatin coming into these platinums coming into these subset of patients because they would be having underlying BRCA-ness or BRCA-like. And then you now have antibody drug conjugates coming into the picture. And but understand the fact that not all triple negatives are behaving the same. They do have differences in heterogeneity and the absence of a definite targetable lesions in these. If you look at this pioneering work, nowadays we say triple negative itself is now around 4 subtypes. You have the basal immune activated, the immune suppressed, the androgen receptor positive, the mesenchymal stem cell subtype, and all of these are now being looked at a molecular level to see do we now look into these triple negatives as different diseases, and then we target or play your therapy based on this. Now, the important things to consider is that if you have a DNA repair issue, that is the HRD or your pathway repair issue, then platinums are definitely known to show an improvement. It's a very controversial thing right now. There are studies which show a benefit. There are studies which show not much of a benefit. So in my practice, yes, if there is a negative subset and all the more the BRCA is positive, I tend to use platinum-based chemotherapy. We do know that there's a role of maintenance maintenance olaparib in these patients or PARP inhibitors in these patients. And along with this BRCA, we look at the BRCA-like genes and the HRD as well. The HRD is a lot more pronounced in ovarian cancer. The studies are still going on in the breast cancer, and it is shown to be beneficial. When it comes to the triple negative subtype, you also have the potential markers like PD-L1, the tumor mutation burden, the TIL score, the MSI, and which all show you a favorable role of giving immunotherapy. If you have an androgen receptor positive, then you're considering markers like anti-androgen drugs into this picture. We also have the PIK3 mutations and the other subset of mutations that come into the picture that drive a second set of pathways in these patients. And then you have other added mutations that can come up in your part of your treatment. We have enough evidence of using PARP inhibitors in the Olympiad, which looked at olaparib, and you had the BRCA study, which looked at razuloparib in these patients and showing you that the advantage of using a PARP inhibitors in patients who have got multiple nights of therapy, there is definitely advantage of using PARP inhibitors in this subset of patients. Now, when we come to targeted therapy, why it is important a triple negative is that based on your PIK3, AKI1 pathway or PTEN mutations, you are now talking about adding targeted therapy in this subset of patients, showing you that in these patients where the outcomes are relatively poor, you do have benefits and you should be sequencing these patients. Now, this is a slightly controversial thing that we want to talk about. How do you select your patients? See, the thing is that what in my personal experience is that I don't sequence all my patients nowadays because I do have my data collected and I realize that there's a lot more that we need to understand. Not everything that you see or every mutation that you see would be targetable, and there is not much of evidence to say that you should randomly sequence every patient. But it is going to be a thing of the future as we understand this more. And here they will give you an example of a patient who has a VRAF mutation, breast cancer. It is not the V600E mutation, it's a different mutation, which in a technical terms may open up the option of using dabrafenib in this patient's downstream and upstream mutation blockage can be done. If you extrapolate the data from immune checkpoint inhibitors in melanoma, then you could say that probably VRAF mutations may help you to have a response to immunotherapy. But then you don't look at a single case study to decide whether it is going to receive an off-label indication, and you'll have to take a discussion with your patient based on what evidence you have. So if you look at the molecular ways, you look at the estrogen receptors, progesterone, then you look if there is discussion about should we do an ESR1 upfront or should we do a gene sequencing upfront. In my practice, I don't do a gene sequencing upfront. Even if the ESR1 is going to be positive, I would still go ahead and use my CDK4 with my AI or whatever it is upfront. But it will be in the back of my mind that this patient probably will not respond too much. That is one thing that I would consider. Like we discussed, when you nowadays, even for sort of hormone positive breast cancer, who has a very strong family history, young patient, you would consider doing your BRCA testing, and then definitely you do have the option of a PARP inhibitor maintenance in adjuvant setting as well as in the metastatic setting as well. So this is what we had already discussed in the previous slides. If you look at the hormone positive breast cancer, not all of them are going to behave very well, and not all of them. There are subset of patients who do extremely well with the hormonal therapy. Some patients will not do all the way to hormonal therapy. Again, today we are discussing about the low ERPI expression, whether 1 to 10% should come under the hormone positive. But if you go into the molecular pattern and see how many of them have an ESR1 expression upfront, how many of them develop ESR expression as we time go, how many of them develop MAPK pathway being activated, all these things are going to play a huge role in the way we manage these patients. This is something we all know about, that is, if you have a PIK3CA mutation, again, it shows you that this patients probably will not respond much to your CDK4/6 inhibitors. Even if you say that I still will not, I do send my patients for PIK3CA mutation upfront for all my patients who are planning CDK4/6 inhibitors, but it doesn't prevent me from using my CDK4/6 inhibitors because the data is not robust to say that you should not use, but it gives me an option of sequencing my patients as I go ahead in my treatment and the disease progresses. And right now, as we run out of options, we look at we can see what are the next options, and the ApoB is one type of a gene that's coming up, and there is some evidence showing that okay, these patients probably, as they develop refractive disease, whether these could be a potential biomarker for checkpoint inhibitors. Now, SOLA1 was a study which looked at this. This is a study that was done at the time where the CDK4/6 was not approved as a standard of care. And the SOLA1 study definitely showed you that those patients who had a PIK3CA mutation had a benefit by adding palbociclib to, had a benefit of adding fulvestrant to alpelisib, and they did only in that subset cohort of patients there was a benefit. But if you go with the biologic study which is done after this, for those patients who progress post CDK4/6 inhibitors, definitely go PIK3CA mutation. There is a benefit of adding PIK3CA, provided you can control the blood sugars and maintain those at an appropriate level. It is a reasonably good option of sequencing your therapy. Now, when you then, this is a phase 2 study looking at those patients with hormone positive metastatic breast cancer who have expressing HER2 also. What you see is the fact that the combination of neratinib and fulvestrant showed you a median PFS of around 5.5 months, which is again a good option of treating your patients, because you would have such a patients who are both hormone positive and would relapse at some point of time. Now, this algorithm looks at a personalized approach. Yes, I would modify it a bit. The fact that irrespective of the PIK3CA mutation, my upfront treatment would be a CDK4/6 with an AI or a fulvestrant, depending upon the clinical scenario. The PIK3CA patient definitely tells me the fact that yes, this patient could be could not respond much. But in my practice, I have had 3-4 patients who had upfront PIK3CA who have always done pretty well with this thing. But the only thing is that they give me an option of sequencing my therapy as I go down the line. And you always have the option of the Bolero study, which looks at everolimus and exemestane, and although if you have a PIK3CA or if you have a PIK pathway activated, and you're opening up multiple options in your patients. If you do a BRCA testing and the BRCA is positive, then it opens up your thing. And always don't forget the fact that as your tumors mutate, you should, when you have metastatic disease and the clinical picture is not making sense, repeat your biopsy to see if there's a change in mutation burden. There's a change in the hormone receptor status as well. Also be aware of the fact that you may have downstream activation of genes which can reverse your BRCA mutation. So it is an important thing for you to understand that BRCA, we all know the fact that these BRCA genes over a period of time, in spite of the fact that they would show a response, would reverse, because you may have secondary mutations coming out that will add resistance and reverse your BRCA mutation, and then the drug doesn't become effective at this point of time. So this is a metastatic CA breast with a hormone positive breast cancer who you would see in clinical practice, whose hormone, who's premenopausal after who undergoes a oophorectomy, gets palbociclib, denosumab, does well for a period of 2 years and 2 to 3 years, and then develops disease progression. This is something you would expect. You would expect a upfront PFS of 24 to 36 months, and the disease would progress. Now, this is a time like I would do my PIK3CA mutation, and then if it is positive, that gives me an option of trying the alpelisib and fulvestrant, provided you're able to control the sugars, because the hyperglycemia is mind blowing, and your OHAs, it basically it is an your insulin putting probably wouldn't work. So it is a life. I mean, they don't go to decay sort, but the sugars can fluctuate a bit if you are not very careful. What we're looking at is, if you look at the HER2 positive breast cancers, is that the new progress multiple lines of therapy. You now have Enhertu, which again is understanding the fact that you have even in low expression, you have a targeted therapy that is able to, even HER2 1+ is able to activate or bring in your focus of treatment to that subset of patients. So you will have options of doing sequencing and then looking at treatment options based on what you sequence. Now, this is what you would expect with trastuzumab and trastuzumab-based therapy, and inflammatory breast cancer, all of you know, is difficult to treat. As you go down the line, what you would see is that we all know that if you have a HER2 amplification, there is level 1 evidence. If you have BRCA mutation, you have level 1. As you come down, unlike the other cancers, what I want to say, remind you, is that you may not find level 1 evidence for every mutation in breast cancer. We are still sequencing breast cancer, because one of the reasons is that if you have a hormone positive breast cancer, the outcomes are reasonably better. So it is as you go down the line that you are trying to sequence. Another thing you need to understand about sequencing is that you're trying to find some sort of patients who may not respond, or who by sequencing you may be able to tell a prognostic marker in these patients as well. Now coming to liquid biopsy, you may be able to do a liquid biopsy of circulating DNA in most of these patients, and there are studies showing that the liquid biopsy and the solid biopsy will show a relatively good concordance. Sometimes the liquid biopsy may pick up more tumors that you don't see in your solid biopsy. That is because the tumor would mutate, and you would be able to pick up other circulating tumor body pathways in your circulation as well. So these are basket trials which look at a cohort of patients who have the same subtype of disease, who, based on the mutations that they have, get into different studies, and you show that, okay, this is what you would see if, based on your pathways that you've mutated, you can target your therapy or personalize your therapy in a clinical scenario. Even then, this is still early, and we are still learning to sequence our treatment as of now. This again is a study which looks at class of your concordance between your circulating DNA cells as well as the outcomes of it versus your paired sample, showing that it is reasonably concordant, and it is an option to try, especially in a metastatic setting where you really can't get a repeat biopsy done. Now, if you look at the important thing is that if you look at these circulating DNA versus tissue genotyping studies, what you see is that you may be able to pick up 84% actual mutations. But the thing is that what you need to understand is that how do you sequence your testing? So I do not do a sequencing unless I run out of options. Even if it's HER2 positive, I would only do it after the second or third line, and the patient is fit, and the patient is going to give me a median survival of at least 3 months, because the testing is going to take time, and the fact that in the clinical scenario, what are the things that you can add to your therapy is something you have to really understand. So if you ask me what's my key point, is that definitely sequencing is going to be a standard of therapy in years to come. In breast cancer upfront, I would not do it. Yes, in early stage, there is a huge role of using gene assay analysis to look at your benefit of using chemotherapy or not. That is definitely a part of your sequencing strategies. In a metastatic setting, most of the time, except in the triple negative, where I would be tempted to do a genetic analysis or a DNA analysis, I would reserve it for my second or third line as of now. But be aware that your BRCA positive cancers can develop a BRCA reversion that is known to happen. And it is important for us to understand these pathways and think that in years to come, maybe not too far, it will be sequencing for most patients, and it will be therapy based on what the patient's underlying genetic sequencing shows. And wherever there's a tissue is an issue, a liquid biopsy is a reasonable option, especially in colon and lung. In breast also, it is showing some promise. Thank you.
Thank you, sir. Thank you for the wonderful talk and finishing well on time. Next, I would like to invite Dr. Nitish Garg for his talk on role of OFS in EBC and duration of endocrine therapy. Over to you, sir.
Thank you. And I would like to thank Dr. Ashwin, sir. It was a wonderful talk. And definitely talking about biomarkers becomes difficult when there is so much change going on. Initially, there were no biomarkers to be dealt with. Only 3 things we were doing. Now it is a huge a load of biomarkers, which the next generation sequencing has opened up for us, and the targets we are finding are a lot many. So definitely the BRCA positive mutations, then BRCA reversing are a phenomena. I had a patient a young lady who was taking olaparib, not responding, progressing within 6 months. So definitely that was the phenomena in her also. So for me, as my talk has been already announced, so I'll start my presentation. I'll be sharing my screen. I hope my screen is visible.
Yes, sir. Just make it full screen, sir.
Okay.
Yeah, perfect.
So I'll be talking about hormone therapy in early breast cancer. And along with that, I'll be talking about the aspect of ovarian function suppression. So first, we will talk about the premenopausal females when we know that there is a role of ovarian function suppression, and also there is a dilemma in how long for the ovarian function suppression to be given. Is it for 2 years, 3 years, or 5 years? So we all know what is the definition of menopause. So it is any female who is 60 or more years old, or a woman who is less than 60 years old with history of bilateral oophorectomy, and also there were no menstrual cycles for the last 12 months without the use of tamoxifen or any chemotherapy or any previous ovarian function suppression. And also she is amenorrheic on tamoxifen with FSH, ESH very high, FSH and LH very high, and estradiol very low. So what are the options of hormone therapy we have in carcinoma breast? So ovarian function suppression, there is a surgical option, radiation to the ovaries, and then there is medical oophorectomy with LH, RH agonist and antagonist. Then the other thing we have is SERMs, which we commonly use is tamoxifen, non-steroidal aromatase inhibitors, and steroidal aromatase inhibitors. So coming to what is the evidence of for tamoxifen in our premenopausal females, this is the early breast cancer trialist group meta-analysis, which has shown that in the patients who were ER negative and compared to ER positive tumors have a better response to tamoxifen compared to control, and improve the overall survival along with disease-free survival. So these were the studies which were included in this EBCTG meta-analysis. NATO was the initial trial in 1988. Then it was CRC adjuvant breast cancer trial, then NSABP B14. So if we see the overall survival at 5 years of follow-up, 15 years of follow-up, the recurrence-free survival compared to the control group improved with a delta of almost 13% compared to the overall survival, which improved to the tune of 6%. So this is the chart showing the same thing, the recurrences in the ER positive patients compared to control. So the recurrences reduced by approximately 12%, 12 to 13%, and the breast cancer related mortality again reduced to the tune of 9%. So then the next question here comes, does the extended hormone therapy with tamoxifen helps in the premenopausal females? So definitely the trials Atlas was adjuvant tamoxifen long and short. So it has an inclusion criteria where premenopausal patients with early breast cancer were included who had have been taking tamoxifen, and there was a disease-free. There was no disease after 5 years and had been continued on tamoxifen further versus placebo. So this was the the demographic profile of the patients. They were well matched. So if we see the survival on the left hand side, we can see the recurrence, and on the right hand side we can see the mortality, breast cancer related mortality rate. So there is a delta of about 3.7% in the recurrence rate. So there is a reduction in the recurrence rate to the tune of 25%, and also the overall survival improved by 29% with the relative risk reduction to 71%. So this was the improvement with the adjuvant tamoxifen given for 10 years in the Atlas trial. So similarly, there was ATOM. So adjuvant tamoxifen offers more. So this was the trial, and a similar kind of a subgroup analysis, similar kind of analysis. So there was a pooled analysis of these two trials, which compared the 5-year use of tamoxifen, 10 years use of therapy was associated, compared to 5 years, was associated with 9-year reduction in the risk of death for whole of the follow-up period. And along with that, 16% risk of death starting from year 10. So the relative risk was 0.84 in the after the year 10, and in the whole of the follow-up period it was 0.91. So this is the chart which had shown which is showing that tamoxifen 10 years improved the breast cancer related mortality with the relative risk of 0.97 at 5 years, and the mortality after 10 years there was a benefit of 29%. So along with that, the pooled analysis also showed the similar results. So then we have been using tamoxifen. So now is there a role of aromatase inhibitors? So definitely aromatase inhibitors does better in the patients who have been premenopausal and have a high risk disease. So optimizing therapy in premenopausal females becomes a question. So the options of treatment here in the premenopausal females are only tamoxifen plus ovarian ablation, tamoxifen exemestane plus ovarian ablation, or ovarian ablation only. So depends upon the high risk profile or the low risk profile of the patient. The first three options are all right. So they can be used very well in the patients. So early breast cancer trialist group meta-analysis has shown that the overall survival improved with the addition of OFS along with the aromatase inhibitor. So when we see 15-year survival, so there was a delta of 6%, and there were 6.3 by 100 fewer deaths. So similarly, the ZIP and intergroup 0101 trial had shown that addition of goserelin to tamoxifen improved the DFS, but there was no improvement in the overall survival. So in 2015, the two trials, SOFT and TEXT trials, were the phase 3 trials, which have shown that there is a improvement in the disease-free survival, and also some improvement in the overall survival, but not very significant. So this was the risk stratification given in the premenopausal females with by the SOFT trial. So it was presence of pathological lymph nodes, large tumor size more than 5 centimeters, or some studies which had included more than 3 centimeters, then the higher tumor grade 3 lymphovascular invasion, and also high risk of recurrence, which is based on the recurrence score testing, and also the women younger than 35 years. Low risk included older premenopausal females, HER2 negative, nodes negative, T1 tumor, grade 1 and grade 2 tumor, ER/PR, which is more than 50%, low Ki67, Ki67, luminal A, and low recurrence scores testing. So initially, the use of ovarian suppression was tested in E3193 trial, which had compared the addition of medical oophorectomy with tamoxifen versus tamoxifen alone. But there was no disease-free survival benefit or overall survival benefit in this trial. So compared to the tamoxifen soft trial, so where tamoxifen was compared it was a randomized 3-arm study where it was divided into tamoxifen plus ovarian function suppression versus exemestane plus ovarian function suppression. So the tamoxifen plus ovarian function or exemestane plus ovarian function suppression group had shown a benefit in the soft trial. So this is the outline or the consort diagram for the two trials which were analyzed together as they have been started simultaneously. So on the right hand side, it is the text trial where tamoxifen plus ovarian suppression versus exemestane plus ovarian suppression were the two arms. On the right left hand side, it is tamoxifen alone, tamoxifen plus ovarian function suppression, or exemestane plus ovarian function suppression. So these were the arms of these two trials. So coming to this different and maybe not a relevant looking chart. So we see here there is something called these patients were randomized based on the HER2 status. So if we see the patients who are HER2 positive, who have tamoxifen, who have been given tamoxifen with ovarian function suppression, even in the presence of HER2 positive, does wonder. But only thing is the patient number is very small to say that it does. There is an improvement of addition of ovarian suppression. But yes, again, it shows that these patients are high risk patient, and adding ovarian suppression, ovarian function suppression will help these patients compared to tamoxifen alone. So, but when we see the exemestane group versus tamoxifen alone, the benefit is not that great. So coming to the disease-free survival benefit, when compared with exemestane to tamoxifen with ovarian function suppression in both the lines, there is absolute improvement in the disease-free survival of 4 percentage points. And when we see that, when we see the freedom from distant recurrence, there is an absolute improvement of 2%. So this is the chart showing that there is an improvement in the most of the arms of the study, except for no chemotherapy arm, where the patients might be very low risk. So addition of exemestane versus tamoxifen with OS might not be of benefit. So this is the cartoon showing all the arms of the two trials and also the comparison. So when we see the soft trial, that is 8-year disease-free survival, when compared to tamoxifen, there is a delta of 4.3%, and the overall survival also improved by 1.8%. When compared tamoxifen plus OFS versus exemestane plus OFS, there is slight improvement in the disease-free survival in survival at 8 years, but no significant improvement in the overall survival. So these are the similar findings which have been mentioned here. So a patient who has received prior chemotherapy, age is less than 35 years. She is a high-risk patient, and definitely there is a benefit of with exemestane plus OFS. When we compare to only tamoxifen, there is a benefit of 16%, and when it is compared to tamoxifen plus OFS, there is a benefit of 7%. So breast cancer-free survival improved with exemestane plus OFS. And when we compare the distant recurrences, there is also an improvement of a delta of 7% with exemestane plus OFS compared to tamoxifen plus OFS. So these were the St. Galen guidelines in 2015. They have told that AI plus OFS offers a better survival in a patient who is younger than 35 years, 4 or more lymph nodes positive, persistent premenopausal estrogen levels after adjuvant chemotherapy. That means patient has not achieved her period, not achieved menopause, and also grade 3 tumor type. And along with that, the tamoxifen in the low risk group can be the drug which can be given in the low risk group can be only tamoxifen or tamoxifen followed by AI, as per the MA17 trial, which has shown that transitioning from tamoxifen to aromatase inhibitor does a improvement in the disease-free survival. So coming to the high-risk patients, so this is the same as per the St. Galen guidelines when we have taken. And so exemestane along with OFS improves the overall survival and the disease-free survival in high-risk patients. The optimal duration of OFS should be somewhere around 5 years. So coming to hormone therapy in post-menopausal females. So we know these are the basic trials we have been reading, that the tamoxifen compared to aromatase inhibitors in post-menopausal females are better. So then it was big 198 trial. It has shown that sequencing from tamoxifen to letrozole or aromatase inhibitor is better. So these are the Kaplan-Meier curves of the same, improving reducing the recurrences when letrozole was given after tamoxifen. Instead, letrozole was given prior to tamoxifen versus letrozole alone. The recurrences are almost the same. So when we give letrozole after following a tamoxifen period of 2 to 3 years, the improvement in the chances of recurrence are reduced by approximately 5%. So this was the IES study which had compared exemestane versus tamoxifen in the extended use. So after 5 years of tamoxifen, exemestane added when it was switched on to exemestane versus continuation of tamoxifen, there was an absolute difference at 5 years of 3.6% in the DFS. Overall survival was almost the same, no significant difference. So these two trials, MA27 and PHASE, has compared what are the aromatase inhibitors which are available, anastrozole versus exemestane and letrozole versus exemestane, and showed that these drugs have a equal efficacy and we can interchange them easily. So this is the monotherapy evidence, what we talk about ATTACK, big 198 and the team trial. So in summary here, all the AIs offer advantage over tamoxifen. There is an incremental benefit of AIs more apparent in the higher risk population. Outcomes are similar in the lower end of risk spectrum. So when we extend the use of the AIs from 5 years to 10 years. So this was MA17 trial, in which the patients initially in the post-menopausal period initially received tamoxifen, then were randomized to letrozole for next 5 years versus placebo. So the primary endpoint was disease-free survival survival, and the secondary endpoints were overall survival. So equally well-matched population. So if we see the results, the distant recurrences in the letrozole group versus the placebo group were quite low. There were a lesser number of new primaries, and also the local regional recurrences were low. So if we follow the patients with the overall survival was not very significantly different. The overall survival hazard ratio was 0.98, but whereas the disease-free survival interval improved. So the relative risk of progression was reduced by 32% in the trial. So this was another trial where the patients were continued beyond 10 years. So letrozole was continued for 6 years of maybe 2 to 3 years of tamoxifen, followed by letrozole for 4.5 to 6 years, followed by extended letrozole use for 5 years. So it has shown that yes, there is an improvement in the 5-year DFS in these patients by the delta of 4%, but again, it increased the osteoporosis chances and increased the chances of bone fractures. So when we see the contralateral breast cancers, the percentage, and the percentage has been reduced by approximately 1/3. So 13% versus 13 cases versus 31% cases in the placebo group. So the two trials, NSABP B42 compared 5 years letrozole versus placebo after initial AI containing therapy, and it did not show a benefit. Then there was a Dutch data trial which was present at the St. Antonio Breast Cancer Symposium in 2016. Again, it had not shown significant benefit of 6 years of anastrozole over 3 years of anastrozole, but except for a disease-free survival index improvement. So this was the ideal trial for breast cancer where tamoxifen aromatase or tamoxifen followed by aromatase was initial therapy given to the patients in the adjuvant setting and were randomized for extended letrozole use for 2.5 years versus 5 years. So this trial had shown that there is a statistical improvement in the disease-free survival index in the patients who are node positive, larger tumor size, more than T5, and tumors which are expressing both hormone ER and PR. Otherwise, there is no much improvement in the patients clinically, and the overall survival was not improved. So this is the basic summary of these trials. So post-menopausal females who are low risk, node negative tumors should not be routinely offered extended therapy, and the patients who are node positive should be offered extended therapy for a total of 10 years. The patients who are receiving adjuvant endocrine therapy should receive treatment no more than 10 years because it will increase the chances of the bone-related events. So this is the summary to the last setting when how long we can use in the post-menopausal setting AI to be used in the population in the females who have a good bone health, younger age, and node positive with luminal A or luminal B disease with high risk genomic score. Thank you.
Thank you, sir. Thank you for your wonderful talk. And next, I would like you to take the proceedings further.
Thank you, madam. So next speaker is my dear friend, sir, and I would like to request Sunit, sir, to take over the podium for the talk on the role of neoadjuvant and adjuvant CDK4/6 inhibitors in early breast cancer. Over to you, sir. So, sir is a consultant at, he's a consultant at, sorry, I forgot the hospital.
Kokilabhen Dhirubhai Ambani Hospital,
Correct.
Indore.
From Indore, he has joined us. Go ahead, sir. Over to you.
Thank you, Nitish. Thanks a lot. Great to see all of you. And nice to see Ashwin after a long time. I met him last time in Adyar some 8 years back. So nice to join back. Thank you for the topic. For fraternity search, it keeps on changing every month and every 2 months. The practice does change. And one of the most striking changes which has come in the last 3 years is the use of CDK4/6 in adjuvant practice. In the last year, probably, I would say. So Abhima had already joined the brigade and we were waiting for the other two to follow. So the subsequent 10-15 slides are basically focusing on the use of ribo in cases wherein we should push it or stress on it. The use of ribo in case of breast with hormone receptor positive and with a combination with an AI will definitely be fruitful for a patient of breast or not. So that is what we'll be discussing it. Mostly the findings are from ML2, MONALEESA-2 and PALOMA-2 to be compared. Subsequently, we'll see what best is there. So I'd like to begin with the permission. And the landscape of CD46 has really evolved to big times. The implications for clinical practice in case of hormone receptor positive and HER2 negative metastatic breast cancer patients or advanced breast cancer. Also, you can take it mostly focusing on the advanced breast cancer. I don't know why I'm busy. So most of my colleagues will not agree with what I'm telling here, but still, it's the slide I have kept here basically is what has been studied and mentioned the paper as well. So when considering options for advanced breast cancer, the primary treatment goal usually which we discuss is either PFS or OS. But this slide clearly says that OS is more an important parameter combined with the quality of life.
Slides are the sorry to interrupt, sir.
I'm sorry. I missed it in the flow. I missed, I believe.
Slides are not visible, sir.
I'll have to quit and rejoin. They are telling me. Can I do that? Can you just give me a second, please?
Sure, sir, sure.
Meanwhile, I can update the score. India is 28 for no loss.
Okay, right, sir. So we are hoping for India's win.
Yeah, is the screen visible now? Sorry, really sorry for that technical glitch, Nitish. Really sorry, went with the flow. So when we're considering the options for advanced breast cancer, the primary treatment goal, what we need to focus is, as per this paper, I'm using this paper is what they mention is overall survival should be the primary goal here, along with the quality of life coupled part, not isolated PFS, which we keep on discussing more or less when we're treating a patient curative intent. So in the setting of an advanced breast cancer, active treatment is generally indicated the goals of providing improved quantity and quality of patient survival. It's the number one treatment goal. Currently, the gold standard is assessing in many trials, which is statistically significant and a clinically meaningful improvement in OS or quality of life is what we need to tell here. It is approved from the US FDA part. What they per se define it as time from the randomization until death from any cause measured in the intent to treat population. So that's what OS is completely defined as, and that's what we'll be discussing in the things further. So I don't think so any of my colleagues will disagree with this statement. Are CDK4/6 game changers in the management of hormone receptor positive or HER2 negative? Absolutely they are. So these three trials definitely gave us the background for these things. Now there is one interesting small story I have. I was doing my DM and one of the consultants at ADR tend to happen to talk to me about these drugs when they were coming up big time. And sir told me these drugs are not meant to come. So I was really surprised by this statement, and he showed me a paper cutting which showed that palbociclib had literally gone to ashes. It was literally been dumped off because it showed events in few of the patients, and subsequently one company came in. Pfizer revived the study, and it was then subsequently studied in 30 pilot patients, wherein it showed a significant effect. And then rest is all history. So these are told to be the drugs which have come out from the grave. Otherwise, the drug that would not have been was the title of the paper, which he showed to me. I still have it in my mail. If somebody wants, I'll share it with them. So from that paper in 2005 publication coming up, and now in 2023, things have taken a long shape, and they've long gone a major change from things. So when we study the three trials, primarily the one considering the one with palbociclib, the Paloma one, or Monarch considering the Abema, and the Mona Lisa showing The ribo use, Mona Lisa is definitely extensively studied trials. So what we basically see is there's a significant PFS benefit in all the three medications, and definitely Palbase is the one to blame because it started the whole game. And what we want to focus on here in the next coming 10 slides is the OS benefit is more with the ribo part and the abema part compared to the Palbase part, which is somewhat lacking in that. So can the benefit in PFS be predictor of OS benefit? Also one long-lasting question, which always has been a part of a debate or a discussion in these cases. I'm just focusing on one of the aspects of it. Please don't kill me for the next 4 slides. So over the past decade, few studies targeted with targeted therapies have reported statistical significant improvements in OS. With the challenges in achieving an OS in advanced breast cancer, PFS become a clinically meaningful endpoint. However, improvement in PFS are not consistently translated into an OS benefit. So this statement is coming from the paper I mentioned below. As with other targeted therapies, improvements in PFS seen with CDK4/6 inhibitors have not been completely linked to an OS benefit. So this is what I want to mention here. If you're able to see me, and what Paloma mentions and what Paloma 3 mentions, 2 and 3, the statistical significance is mentioned in the graphs. So the hypothesis coming out is different patient population in different trials was used. Different post-progression treatment in trials was used, and different pharmacological characteristics of CDK4/6I are there when comparing 3 drugs. So you should not mix all the 3. And because the difference in patient population in trials is there, one shoe doesn't fit all also applies in the modern context here when I'm talking about it. So when we consider the patient population in different trials and compare them and study them focused in a different manner, or we match certain characteristics of certain individuals so that we have a rational base to compare 2 molecules, that actually makes more sense in discussing this kind of thing. So we took Mona Lisa 2, they took Paloma 2. They did something known as a matching adjusted indirect comparison. So they matched certain populations, then they did a comparison, and this comparison was used to compare relative effectiveness of treatments of the 2 drugs. So this is what was randomization. This was the patients were mostly postmenopausal. Primary endpoint here was again PFS. Prior chemotherapy was not allowed, and the excuse me for this. And stratification factors have been mentioned in the slide discussed. So what they did is they took matching population from Mona Lisa 2, they took matching population from Paloma 2. They were weighed to match average baseline characteristics of Paloma 2. Population matched and balanced. So total number of patients in Mona Lisa 2 were 262 compared to the 666 in Paloma 2. So balanced populations were taken. Now, matched assessment revealed a numerical PFS and significant OS benefit with ribociclib over palbociclib is what's being stated. What you can see here, when the matched patients were assessed and compared with the Paloma ones, what they found out, the HR was very significant, the hazard ratio was very significant in terms of PFS and in terms of OS, favoring ribociclib plus letrozole compared to Palbase plus letrozole. So it demonstrated a significant OS benefit when compared with the matched areas. What I'm mentioning here is we are removing other biases, other errants, and matching the areas on a single base. So the problem of different patient population in trials is abolished here. Again, different post-progression treatment in trials. So this is something which is tough to match. And many patients go on to have chemotherapy, many patients go on to have continued endocrine therapy, many patients go on to have no therapy at all. We lose some patients also in between. So post-progression treatment in trials is also different. That also is a different baseline parameter. So what they did is they did a pooled analysis of post-progression treatments after first-line ribo plus endocrine therapy in patients with hormone receptor positive, HER2 negative advanced cases of Mona Lisa 2, 3, and 7 studies. And this was presented. So what they told is the most common subsequent therapies between 2 arms for the patient, endocrine therapy was common, followed by chemo. For patients with the placebo arm, chemotherapy was most common, followed by endocrine therapy. And patients wherein targeted therapy was given, the number of patients receiving CDK4/6 as a first subsequent therapy was greater for placebo versus ribociclib itself. What we need to state again, in all treatment categories other than chemo or other, which you mentioned is basically the ones which are not classified, the duration of first subsequent therapy was longer for patients with first line ribociclib versus once with placebo, what you can appreciate here in the forest chart very clearly compared to the placebo chart. In Paloma 3, Palbase showed similar or numerically shorter duration of next line therapy compared to placebo, giving it a significant advantage. And we can go on to tell that definitely CDK4/6 are the game changers after seeing these two slides. So different post-progression treatment trials with possible carryover effect of ribociclib. Now, coming to the pharmacological characteristics of CDK4/6 inhibitors. So the next 4 slides basically focus on 2 points. CDK4 plays a more important role than CDK6 in breast cancer. Of course, CDK6 lines were more hematopoietic in origin. CDK4 dependent lines were most commonly seen in estrogen receptor positive breast cancer lines. Okay, CDK4/6 inhibitors have differential activity towards different targets. Ribo and Abema are more active against CDK4 than CDK6 in both CDK-dependent cell lines and biochemical assays. When a head-to-head comparison was done, Palbase fared lesser compared to Abema and Ribo. Now, giving this, they have fewer interaction with off-target kinases than Abema. The Ribo is superior here, that is. It achieves the higher levels of exposure in plasma, that is also mentioned here. What they mentioned is an AOC steady state and free drug exposure normalized to palbociclib in comparison to the Ribo had much higher times concentration than Palbase if compared as a standard. So this is also checked part. So comparing all these 3 variants or issues which are usually there when you're comparing 2-3 different styles of different drugs, after addressing these, so we should definitely appreciate that which which CDK4/6 inhibitors do guidelines recommend. All of us know about Abema, but now Ribo has come up as a big time one. The 2002 guideline recommending any of the 3 now guidelines recommending ribociclib as category 1. So this is what is there. Now, ESMO has brought up a beautiful thing by the name MCBS. It's a rational and structured and consistent approach to derive a relative ranking of magnitude of clinically meaningful benefit. So nowadays they compare everything on MCBS. So in that also MCBS scoring. Just a sec. Hello. Sorry for that. I had an emergency call from the emergency. So ribociclib fares well here, which we can able to see according to MCBS scoring of ESMO. So after seeing that, guidelines are also placing ribociclib above Abema on the benefit part. Now, do you believe the consistent OS benefits with Ribo extend to difficult to treat patients as well? So this evidence of Ribo there in subgroups which are difficult to treat. So what they have mentioned here is this only. The significant benefit of Ribo is extended to patients with visceral mets and liver mets. We are not talking about for the crisis. We are talking about the liver mets and the visceral mets in pooled analysis of MONALSA trials. OS in patients with visceral mets, relative reduction in risk of death was around 20%. In patients with liver mets, there was a 29% relative reduction in risk of death. So this is a line which we all have answered when it comes to Palbase or Abema also. Does dose reduction have an impact on efficacy? No, it's a long sorted question. What about CNS Met patients? Can Ribo be used in this group? So there's a very beautiful slide telling that patients with CNS Mets in complement one have a trend towards longer time to progression. So MTD was not reached for patients with CNS Mets who are already having Ribo. So what if this patient who had visceral mets also presented with an aggressive disease, the visceral crest is excluded? Which should we consider Ribo plus AI over a chemo? What is the evidence within such a group? So there's a study by the name Right Choice study, which aimed to evaluate the efficacy of Ribo plus AI versus combination CT in premenopausal patients with aggressive disease in first line setting. You can see the inclusion criteria here: pre-perimenopausal women, hormone receptor positive, measurable disease, patients with aggressive disease, the ones with visceral mets, the ones with rapid disease progression as well. Now, I will not comment on the visceral crisis part. So these patients were taken up and the patients were compared when Ribo was given compared to when CT was given, and evaluation was done every 6 weekly and then every 8 weekly. The primary endpoint definitely was PFS. So if you can see the graph here, you can appreciate the delta part of things. And it is very significant that combination CT versus compared with Ribo plus AI is giving good result. Ribo plus AI definitely, when you compare other parameters also, is faring well compared to the chemo part. So the overall response in treatment to time to relapse was similar between ribociclib plus AI versus combination CT. So it's an at par thing. Definitely ribo rules the roost in these cases. So to summarize, it's the only CDK4/6 inhibitor to significantly improve OS across all lines of therapy, endocrine partner in menopausal status. It is the only CDK4 with proven 2 times PFS benefit as per Right Choice study in comparison to chemotherapy. Only CDK4/6 to be recommended by NCI in 2023. Proven quality of life benefit that has got the highest ESMO MCBS score of 4 and 5. Due to different pharmacokinetic and pharmacodynamic profiles, ribo has the highest selectivity for CDK4, has the highest free drug concentration and potential impact on observed differences in efficacy and safety. I'm very promising with that. Thank you for listening to me. Thank you for your time. Thank you, Nitish, for this chance. And I'd like to stop my screen sharing here.
Yeah, thank you, sir,
Nitish.
for the wonderful talk. And definitely, I would like to comment upon the chemotherapy arm used in Right Choice. I was not very convinced what kind of combination was used there. So though
there is always space for argument. There is always a space for discussion.
Otherwise, ribociclib has changed the spectrum, no doubt.
Yes. These 3 drugs have literally changed the spectrum the way we used to learn, and definitely they are ruling the roost now in one way or the other.
Even in the neoadjuvant setting, there have been 3 or 4 trials in the phase 2, which may be leading on to the phase 3 trials. So NeoMonarch is one of them, which has shown that addition of abemaciclib reduces the chances of cell cycle progression. So even targeting a cell cycle progression and reducing the number of proliferation number Ki67 from 20% to 2.2 or 2.7 has made a bigger difference in these trials. So these trials are to be looked forward when the results will be out. Thank you, sir, for the beautiful.
Thank you, Nitish. And Jagdeep Virji, hello.
Hello.
After 5 years.
How are you? And seeing you after a long time.
After 5 years, 5 साल बाद मिल रहे.
अभी जबलपुर में?
अभी सर जबलपुर छोड़ दिया है मैंने इंदौर now.
Good. नीतीश की वजह से तुमसे मेल हो गया.
हाँ बिल्कुल, नीतीश की वजह से ही मुलाकात हुई और मैंने अश्विन भाई को भी इतने सालों बाद नीतीश के कारण ही देखा.
Nitish, means I met him in Adyar in one of our the training programs.
होता था ना, Cope used to be there. We met in Cope.
Yes.
Yeah.
So there he told me that he's from Jabalpur because I did my MBBS from Jabalpur.
Okay.
So happy to see you.
Currently at that point of time, हमारी जूतों की चॉइस भी सेम थी. हमने एक ही कंपनी का एक ही जूता पहना हुआ.
Actually, टीचर से जूते खाने की भी चॉइस सेम थी. सुनीत अपना नंबर मैं I'll just send my number on your personal message.
I'll send mine as well. Sir. I'll send mine as well. चलो. Thank you, Nitish.
Thank you, sir. Thank you.
Thank you. चलो जगदीप भाई बिल्कुल.
आपको करता हूँ पर्सनल मैसेज पे नंबर.
Sir, kindly unmute yourself.
Yeah. So for next talk, it is a panel discussion. So it is management of hormone positive early breast cancer, which is sponsored by INTAS. I would like to invite Dr. Gurvinder Singh, who is a medical oncologist at CCA, our SPS Hospital, Ludhiana. Welcome, sir. I would like you to take over the session, please, and invite your panelists. And I would like Dr. Jagdeep to be part of it, sir.
Thank you for invitation. And we'll be discussing a panel discussion on hormone positive breast cancer. Nitish, slides are visible?
Yes, sir. Yes.
Okay. So our panelists are Dr. Navdeep Singh, Navdeep is here.
Yes, yes. I was.
Okay, Doctor. Hi, Navdeep. And Dr. Kanika Sharma.
Yes. Hi, good evening, everyone.
Good evening.
Good evening, Dr. Kanika. And Dr. Nitish.
We can add Dr. Jagdeep also. I think sir is there.
Yeah, Dr. Jagdeep.
Gurinder, I'm here.
Okay, done. So it will be a case-based discussion what we are doing basically in our clinics. So a 59-year-old postmenopausal lady, non-metastatic disease basically evaluated, and she underwent upfront surgery, modified radical mastectomy, and post-op specimen is 3 centimeter single tumor, grade 3, single.
Nishant, is there some connection issues? Let me talk to Dr. Gurvinder.
Next slide, please.
Okay.
So yeah, Dr. Kanika, this lady has come to you post-surgery, 59, post-menopausal, no comorbidity, well-to-do, financial, no issues, and ERPR HER2 status, ERPR positive, HER2 negative, single node positive out of 11, grade 1 tumor. What will you advise for further?
So, if the patient is affordable, then I would like to get an Oncotype DX done for her.
Gurvinder, you are on mute.
So, okay, Oncotype DX, we discussed the cost. It is around 3 lakhs. So, not that affording.
So we can go with that Indian version of, I think, some Can Assist, right? I've not used it in any patient.
Okay.
Can Assist. Otherwise, in some patients, I do give 4 cycles of chemo and then start on hormonal also.
Node positive also for
A single node positive out of 11, strong hormone positive around 59, grade 1, yes.
okay. Dr. Jagdeep, what regarding Memaprint, Can Assist, Oncotype DX, how you take these 3?
So if you ask me, Kanika is correct that we can do Oncotype DX because there is a strong evidence of from the RxPonder trial. This post-menopausal female who were having T1 or T2 disease and with the N1, that is node 1 to 3 positive. And there are potential candidates which can be which can skip the chemotherapy in these patients. And Mamaprint means if you go with the MINDAC trial, so that is not for the patients who are, I think, node positive. I'm not sure about that. But RxPonder is specifically post-menopausal node positive 1 to 3 and T1, T2. That will be the perfect. And for Can Assist, means if you go, it's the data is all retrospective. There is no prospective data for the Can Assist. So going with that, there is no financial constraint. I will go with definitely Oncotype DX with this patient.
And MINDAC, yeah, definitely it is for node negative. But how convinced you are with that data?
MINDAC trial, if you ask me, means I'm not so very much convinced. I think better to go with the Oncotype DX. I will be comfortable doing that.
And I think it is only a prognostic instead of a both predictive and prognostic.
Yes. So
yes. That's another point, important point.
Actually just compared that if we go ahead with the clinical suspicion that this is a low risk disease and compared that on a genetic basis or a gene profiling, this is a low risk disease, that is what it had defined. So looking at that data, is it concordant with our clinical profile? Yes or no? That is what I could recall, that this was the outcome of the trial, and it was those patients who are clinically low risk, they tend to do better, and also they have high chance to be low risk even on genetic profiling.
So definitely it is not for, and the study was not powered enough for defining the benefit of chemo, even if they are high risk genetically, though low risk clinically. So she underwent Oncotype DX, recurrence score was 16. And Dr. Navdeep, recurrence score is 16, Oncotype DX. And what will you offer her?
Ravinder, you are choosing exactly boundary line values. I think well planned with this case.
No, it is a post-menopausal.
You are choosing the boundary line values where whether it's a no baller or 6 on that no baller.
Dr. Navdeep. Okay, Dr. Jagdeep, ਤੁਸੀਂ ਲੈ ਲਓ. Recurrence score is 16.
Definitely in post-menopausal woman, I will go with that only hormonal therapy. If it is a pre-menopausal, in that RxPonder it is clearly mentioned. For a post-menopausal, for 16, you can go with the hormone therapy.
Yeah. Pre-menopausal lady, less than 25, definitely. No benefit was in post-menopausal. Definitely there was no benefit. So we can go alone with hormone therapy. Next slide, please. So she was planned for letrozole. And what duration of adjuvant letrozole you choose in this lady? Dr. Navdeep?
So minimum 5 years and can be extended up to 2 to 3 years more. I would ideally do for 5 years.
Okay, 5 years. Why not going for 10 years or 7 to 8 years?
So I think the side effects. I think there is a trial with that phase 3 data with anastrozole also. The risk of bony fracture is slightly bit more with the higher dose, higher duration with the 10 years, and can be safely the benefit is around same if it is given for 7 years. I think duration could be can be done little less.
Yeah, 7 versus 10. 7 was as equivalent to this 10, and the risk of bone fractures were less with 7 as compared to 10. So, Dr. Kunal, yes, definitely radiation, but we are not discussing basically on radiation.
But if MRM is done and one node positive, no other risk factor, even 1 to 3, we can omit radiation also.
Yes.
I think one node positive.
Grade
should-
1 and no other risk
One
factor.
was positive and RX
Correct.
responder.
I think that was the reason I put it there. But I think that information that is for subset of patients 65 or above. I'm not sure if 59 may be a borderline.
But
You may
this
make a
lady,
case
I think, will need radiation.
correct. So, but 65, this 1 to 3 nodes, even radiation can be avoided.
Above 65, yeah, definitely.
Of 65, yes, sir. And if we see the recurrence score, if it is less than 25, so here it is 16, definitely there is a subgroup analysis where in the RX responder trial only that the radiation can be avoided with the single node or 1 to 3 nodes being positive with the lower recurrence.
So, who are the subgroup of patients in whom we can just go away with 5 years of adjuvant hormone therapy, Dr. Kanika? Not needing extension of therapy beyond 5 years.
Again, like in this patient, since she is not an high-risk patient, 59, grade 1, only one node positive, we can go ahead. Yeah, if the nodal burden is high, the patient is younger or grade 3 disease. So in that case, I would like to go ahead with for 7 to 10 years of hormonal therapy. But in this patient, 5 years is sufficient with low clinical risk, basically.
So you're definitely T3, T4 disease, high grade, and 2
High.
and 3.
Yeah.
So, okay. Next slide, please. Case 2. So this is a premenopausal lady, 42 years old, clinically T2N0, non-metastatic left breast carcinoma, post breast conserving surgery with lymph node dissection, single tumor, 4 centimeter, grade 3, 4 out of 12 lymph nodes, ER strong positive, PR 5/8, HER2 is 1+. Then this patient received dose dense 4 cycles chemo and followed by 4 cycle taxanes, and along with that radiation, and tamoxifen was started post chemotherapy. Dr. Nitish, what further you would like to do for this lady?
So 42, and I would ask her about her menopausal status as she has already received chemotherapy. Is she to chemo induced? Even though she's in that phase, she is a high risk candidate. So as per the soft and text, if she fits into high risk, I would add on ovarian function suppression. So
Okay, definitely.
so the age is still dicey. Usually the soft and text says 35. Here again, it may be a benefit, but definitely there will be some benefit which we are sure of. Along with that, maybe a BRCA testing to be done, germline BRCA testing because she's young, though it is ERPR positive.
So yeah, germline BRCA1, BRCA2 testing was done. It was negative. And ovarian function suppression, definitely we should add if she is still premenopausal post chemotherapy and getting estrogen levels or ALH, FSH post chemotherapy, because she will benefit. So how convinced you are with this adjuvant abemaciclib data? Dr. Kanika?
I am using abemaciclib, especially in younger patients. So with the latest update on that trial, actually there is a benefit with adding abemaciclib. And if the patient is premenopausal, so all the three, ovarian suppression and along with the abemaciclib and letrozole or any AI. So since the nodal burden is high, 4, and patient is only 42, so I would use all the three in her, basically.
Dr. Jagdeep, how much you are convinced with the monarchy trial till now?
So I concur what Kanika said. So this young lady, grade 3 tumor and 4 lymph nodes positive, definitely adjuvant CDK4/6 will be beneficial to this patient. So definitely I'll give.
Yeah, definitely this is a high risk subgroup according to monarchy trial. And the 4-year DFS benefit is roughly around 6 to 6.4%, I think. Next slide, please. Case 3. No, just take it on case 3 slide. Yeah, that's it. So this lady, she's 86-year-old, diabetic, presented with carcinoma left breast, high grade with 8 into 7 centimeter lump with pseudoedema, with a mobile left axillary node 2 by 2 centimeter with non-metastatic disease. And ERPR HER2 was done on the biopsy, which was strong positive with HER2 1+. She's elderly, diabetic with a ECOG performance status of 2. Dr. Navdeep, neoadjuvant treatment, what will you like to offer to her? Elderly, frail lady with diabetes.
So I think thinking of chemo, it would be difficult. I don't think so. Hormone positive, whatever, if you use hormonal drugs, the PCR rates achieved will be very low. And I'm not sure exactly how much duration of the treatment should be given. Whether it's convincing about this.
Any experience with such kind of patient till now?
No.
Dr. Jagdeep?
Definitely there is evidence of neoadjuvant endocrine therapy, but honestly I have not given. So patient who are old, frail lady like this, which we are telling of 86 diabetic, and she's having a bulky disease and with a lymph node positive and grade 3. So definitely if this patient I encounter, I'll definitely challenge with the neoadjuvant endocrine therapy. And I'll proceed. I mean, chemotherapy definitely I will not give in this patient.
So there was one lady around 87, 88. I dealt with at Sangrur, not here. And she was like fitting into same category. Diabetic with she was cardiac also, 87, 88. So I used it with the palbociclib along with this letrozole for 3 months or 3 to 4 months, I think. But she underwent surgery and all. So yeah, you are right. Data is scarce. And it is just phase 2 data, not phase 3 also, because phase 3 they have compared in premenopausal hormone, neoadjuvant hormone versus neoadjuvant chemotherapy. The response rate is higher with chemo as compared to hormonal therapy, and but there is a response. Some patients can be dealt with, but definitely not as of now standard of care. Dr. Kanika, have you encountered such a patient and have you used neoadjuvant hormone therapy?
So in one patient, we have used for 3 months, but the disease was aggressive. Patient was not fit for chemotherapy, but after surgery and even radiation, also there was a chest wall recurrence and now started on CDK4/6. We have given in the same scenario HER2 positive only trastuzumab and pertuzumab to the patient, and patient had a good response to that without chemotherapy in elderly patient. So
Kunal sir, you can do a phase 3 trial at DMC for such kind of patients. Dr. Nitish.
You need to send, all of you need to send all your patients then today.
Okay, definitely you will get from my side, don't worry.
Here I'll say there are two options of treatment if we are very sure that it is a non-metastatic disease and at the age of 86, why don't we offer her surgery first and then the hormonal treatment?
But this kind of disease, the margins will be an issue.
It is a kind of disease which tend to reoccur early. So definitely role of hormone therapy in the neoadjuvant setting as per the NOAA trial. So along with that, I would like to add the ribociclib as the newest data from Neoplana trial, which is phase 2, has shown that reduction in the Ki-67 index has shown the improvement in the overall survival. Though the patients there were about 150 or to 130, something like that. So it will be a follow-up study going into a phase 3 data. But again, the responses will be better if we give. And so they have chosen like 4 weeks of anastrozole followed by 16 weeks of ribociclib plus anastrozole. So this was the trial design. And then they have done surgery after 6 weeks, 5 to 6 weeks.
Yeah, definitely CDK4/6 can be used depending if we get such kind of patients who are not fit for chemo, who are not eligible for surgery upfront. Definitely.
Otherwise, we have to check what we read about a PEPI score, that is there a reduction of Ki-67 after 2 or 4 weeks. If there is a reduction of Ki-67, then we continue using hormone therapy alone for about 3 to 4 months and then go for surgery. If there is no reduction, then better to offer the patient surgery upfront or do chemotherapy to.
So any data that is like tamoxifen versus letrozole in neoadjuvant setting, which is better?
I don't think we have that kind of data.
There are some studies, phase 2, that these AIs are having better clinical responses than tamoxifen in these sort of patients. And fulvestrant also people have like compared in phase 2 where the AIs, fulvestrant was not better as compared to AI alone. And yeah, that's it. Thank you. Thank you, everyone.
Thank you.
So thank you, Dr. Gurvinder, for a wonderful panel discussion and the discussion overall. So for the next session, which is sponsored by Roche, I would like to call Dr. Devinder Paul. So he's head and consultant medical oncologist at Fortis Hospital, Ludhiana, for his talk on neoadjuvant chemotherapy in HER2 new positive early breast cancer. Over to you, sir.
Hi, Nitish, how are you?
Fine, sir. How are you?
I'm good. I'm good. Thank you for inviting. So can somebody share my slides? Am I audible to all?
Yes, sir.
Okay. So good evening, everybody. Thank you, Nitish, for this invitation. The job given to me is to talk a little about the transforming journey for the HER2 positive breast cancer patients who are requiring a neoadjuvant treatment. Next slide. So these are my disclaimers. Next. So now we have ample data to show that the dual HER2 blockade had a proven role as far as the disease for HER2 positive breast cancers are concerned, whether it's a neoadjuvant setting or the adjuvant setting, and of course the metastatic setting. It all started with the metastatic setting, and the data was then tested in the adjuvant and followed by the neoadjuvant setting. So the pivotal studies for the neoadjuvant trial is the Neosphere trial. For the adjuvant is the Affinity, and for the metastatic, we all know the first trial, that is the Cleopatra. All of these studies have been corroborated additionally by some additional studies. And now we can say with quite confidence that Perjeta Herceptin plus chemotherapy is approved and is recognized by all the international guidelines as a standard of care for the patient with HER2-positive breast cancer, whether it's the curative setting or it's the metastatic setting. Next slide. So you can see from this flow diagram for the patient who comes for us with a newly diagnosed HER2-positive breast cancer who are curable, whether it's a localized, operable, or a locally advanced tumor. If the disease is CT1A and 0, people can go ahead with surgery, but now the people are making some noise about this also, that even if the tumor size is more than 1 centimeter, we have a data to show that the neoadjuvant dual HER2 blockade has a role. But if the patient has a tumor size more than equal to 2 centimeter or node positive, of course, neoadjuvant chemotherapy plus anti-HER2 therapy is the standard of care. And now we have data for the dual HER2 blocker with trastuzumab and surgery. We give neoadjuvant this treatment followed by surgery. And depending on what a very important marker, which is the pathological complete response, we decide the adjuvant treatment. If there is a residual disease, we have ample data to show that the adjuvant TDM1 has a good validity. And if the patient has achieved a pathological CR, we can continue with the dual HER2 blockade. And in some patients in whom it is not possible because of financial constraints, we can go ahead with just trastuzumab. And similarly, in the patient who underwent upfront surgery, if there is node positivity, if there is a node positivity, it is better to give the dual HER2 blockade. And if the patient is node negative, we can go with just trastuzumab along with chemotherapy in the adjuvant setting. Next slide. So regarding why this whole fuss about this subcutaneous formulation, because the IV formulation of Perjeta and trastuzumab, although it's well established, but can present a lot of challenges in our setting, especially in the Indian setting, because there is a long infusion time, observation time post treatment, post infusion, and there is a challenge for improving the resource utilization, placement, and maintenance of indwelling cutaneous catheter is also a big challenge in our part of the country because of the maintenance of the chemo port and the IV line, because infection rates are high. So and some patients, there is even with these also there is a challenge for venous access of these patients. So taking all these things into consideration, the fixed dose subcutaneous preparation of this Phesgo was came into picture. Next slide. So how is Phesgo? Phesgo is the first formulation in oncology to combine two molecular antibodies, that is the pertuzumab and the trastuzumab, in one vial subcutaneous injection. It contains the same antibodies as approved for the IV pertuzumab and trastuzumab, but has a different route of administration. It is formulated with a recombinant human hyaluronidase to allow for the subcutaneous administration of a higher drug volume, that is around 15 to 20 ml loading dose, and the maintenance dose is around 10 ml. It is a ready-to-use fixed dose formulation, and it is administered by a subcutaneous injection in the thigh over a period of 5 to 8 minutes. Next slide. So what's the role of this impact of this hyaluronidase on the subcutaneous injection? You can see on this the diagram on the left side, the subcutaneous layer of our skin contains a matrix of hyaluron fibers and collagen fibers, which limits the subcutaneous administration of volumes of less than 1 ml. However, the addition of this enzyme temporarily to Phesgo temporarily and locally degrades the hyaluron at the injection site with no changes in the structure, providing macromolecules, collagen and elastin. And the degradation of this fiber results in a temporary increase in the local subcutaneous dispersion area, enabling a large volume of fluids to be administered. So after subcutaneous administration, the architecture of the skin is reformed within 1 or 2 days due to rapid clearance of this enzyme and a fast hyaluron turnover. So the formulation with this enzymes allows the subcutaneous administration of a large volume, that is more than 1 ml. Next slide. You can see from this diagram on the left side, if we do not give this enzyme before an infusion, after immediately post infusion, you can see a large lump forming, which can be painful also. But once we give this enzyme along with the drug, you can see that immediately after post infusion also, the patient has minimal swelling and minimal pain. Next slide. So does this fixed dose combination have a same pharmacokinetics, efficacy and safety as the IV formulation? Next slide. So there was some phase 1, phase 2 and phase 3 ongoing studies. Phase 1 study was the BO30185, which confirmed these finding and finding the dose of this drug. And there are few phase 3 studies ongoing. The initial analysis have been presented a few years back. Next slide. So that's phase 1B BO30185 study. It was given in multiple cohort setting in healthy male volunteers, and later on some early breast cancer patients were also taken into consideration after the dose finding was confirmed. Next slide. So the summary of this study was that they selected a loading dose of 1200 mg pertuzumab subcutaneous and a maintenance dose of 600 mg pertuzumab subcutaneous to be used in PESGO. The PK data in healthy male volunteers and patients with early breast cancer predicted that the doses, these doses resulted in equivalent pertuzumab serum exposure to that of data IV 840 mg and 420 mg in the maintenance setting. These dose finding process used to find the subcutaneous dose of pertuzumab was similar to those used successfully in the development of both Herceptin subcutaneous and the rituximab subcutaneous. And there were no new safety signals observed with the subcutaneous formulation, and the PK and safety results from these data, they supported further development of PESGO. Next came the phase 3/2 study. First was the Frederica study, and which was phase 3 non-inferiority study. And you can see the stratification, and these were done primarily once the patient was started on these medication after surgery, and they are adjuvant setting, and these were given, and follow-up studies were taken, follow-up data was taken into account. Next slide. So the basic, but once we do the PK studies, the main things which we take into account is C trough value, the AUC, and the Cmax. And you can see from these, these formulation fixed dose subcutaneous formulation had an equal or sometimes even the better, these markers, these objectives were obtained in a better way. Next slide. So the primary endpoint of plasma serum C trough level of whether it's of Herceptin or that of the pertuzumab, both were equal or even in some cases the better. So the lower limit of 90% confidence interval for the plasma serum C trough of the Herceptin and that of the pertuzumab, they exceeded the non-inferiority margin of 0.8. Next slide. Similarly, the tissue-specific CR rates in the intent to treat population were almost equivalent in both the studies, and they were keeping in with the data from the previous studies of the IV formulation. Next slide. Regarding the safety profile, the rates of treatment discontinuation due to AEs were similar between both the arms, and the primary grade 3 toxicity were primarily because of the concomitant chemotherapy. Per se, these formulations, whether it's the IV formulation or the subcutaneous formulation, they were quite amenable to succeed. Next slide. And the incidence of AE were consistent with other studies that included the IV formulation. You can see in both the arms, the rate of alopecia, nausea, diarrhea, anemia, and asthenia, which are primarily because of the concomitant chemotherapy, were equivalent. Next slide. And of course, the incidence of AE of interest, including the cardiac dysfunction and infusion reaction hypersensitivity, they were also comparable in both the arms. Next slide. And there were no meaningful difference in the cardiac safety, whether at the primary cardiac event or the secondary cardiac event, they were all equivalent. And the LV decline of more than 1 degree was also equivalent in both the arms. Next slide. So from these phase 1B and phase 3 study, they showed that the fixed dose subcutaneous formulation had a non-inferior PK as compared to the IV formulation with comparable efficacy. It was non-inferior to the IV formulation, and the pathological CR rates were almost equivalent. That's 59.7 versus 7%. And the safety profile of the fixed dose combination was comparable to that of IV formulation, and there was no additional adverse event which was found in the subcutaneous arm. Next slide. So then there was a study which showed whether the patient preferred the IV formulation or the subcutaneous formulation. Next slide. This study was the France SCA study, phase 2 study. In this, the patient was treated as per the protocol. They gave initially, they were randomized to either the IV formulation or subcutaneous formulation. And after 3 cycles, both were switched. That is, IV formulation was switched to subcutaneous, and the subcutaneous formulation was switched to IV formulation. Next slide. In the neoadjuvant setting. So the preference for the subcutaneous formulation was fairly strong for the majority of patients. Main reason for subcutaneous preference was less time in the clinic, more comfortable during administration, and 87% choose the subcutaneous formulation as the maintenance. Next slide. So, more patients were very satisfied with the subcutaneous formulation. That is 88% versus 68%. And treatment had no impact on the patient and the doctor speaking time. Most patients had more than enough time to talk to the healthcare professional during the treatment in the subcutaneous arm. Next slide. And the majority of even the doctors felt that switching from IV to subcutaneous formulation would save the time and resources. The drug preparation room, the drug preparation, you can see from 20 minutes came down to 5 minutes. And the 88% of the doctors thought that the fixed dose combination was the quickest form. And similar percentage of patients found that the subcutaneous formulation required less resource usage. And around 80% patients agreed that the ready-to-use fixed dose combination resulted in less drug wastage. Next slide. So in the France adverse effect, you can see rates before and after switching was similar with no new safety signal, which is very important because once the patient shift from IV to subcutaneous, she should have that much of confidence that the AEs are not going to increase. Next slide. 85% patients in the study preferred the subcutaneous arm, and only the 14% preferred the IV form. And main reason for the subcutaneous preference, as I told us earlier, was the less time in clinic and being more comfortable during the drug administration. Next slide. So what are the practical considerations for using this fixed dose combination in the real world? Next slide. I think these slides are more for the daycare staff, but we should also know how to give this drug. And these are tips to ensure comfortable drug delivery. The patient will sit back in a reclining chair. Be sure to arrange your chair at the right angle, and your aseptic protocols have to be taken into consideration importantly. And the injection site should be altered between left and right thigh or only. It is not meant for any other site of administration. And it is never to be administered in the abdomen. And do not split the dose between the two syringes or between the two sites of administration, even with very slim patient. And fixed dose combination should be used in a safe and comfortable manner. And each new injection should be given at least 2.5 centimeters from the previous site, and choose an area of the healthy skin that is not red, bruised, tattooed, tender, or hard. And we have to record the use site for the patient note. Next slide. And to administer the drug, we have to pinch the skin of the thigh with one hand to create a fold, and at a 30 to 45 degree angle, we have to administer it. And we have to maintain the needle at the angle of around 30 to 40 degree. And if at any point during the injection the patient feels pain or discomfort, we have to ease off the injection before continuing. And we have to keep the needle in place and check to make sure that the needle is at the right angle. And the injection should be slow and paused. The injection should be discontinued immediately if the patient experiences a serious hypersensitivity reaction. And we have to make sure that the medication reactions are well arranged. And after the loading dose, the patient should be observed for the minimum 30 to 45 minutes for the signs of hypersensitivity reaction. And after the maintenance dose, the patient should be observed for a minimum of 15 minutes. Next slide. So regarding the best practice, we know that treatment, depending on the patient outpatient setting, the dose can be administered on a dedicated date. Having a room, single room for administration and observation gives the patient enough physical privacy. And if the drug is administered in the chemotherapy daycare unit, curtains or other shades are required to ensure the patient privacy. A blanket on the top of the patient lower abdomen and pelvis may make them feel less exposed. And to ensure the patient comfort during administration, a bed or reclining chair is preferred. And nurses should have a comfortable chair and removable drug table to ensure quality and safety of administration. Next slide. So what can Phesgo mean for patient and the doctors? Next slide. So it provides a benefit in the cost time reduction for the patient and the doctors. Shorter administration time, that is 5 to 8 minutes, and the observation period of just 15 to 30 minutes reduces the burden on patients and their caretakers and the healthcare professionals. It is less invasive administration versus IV, which is 2 separate IV infusions. It frees the patient from the burden of IV pain, bruising, and irritation. And this combination may reduce the risk of dosing errors, reducing the drug wastage, and increases the availability of the nursing and pharmacy staff for other tasks. And reduced time required for drug preparation and administration with this combination has the potential to relieve strain on the infusion centers. And as we know, there is no new safety signals have been observed when switching from the IV to the subcutaneous formulation. Next slide. So overall summary, Phesgo is the first formulation in oncology to combine the 2 monoclonal antibodies, that is the pertuzumab and Herceptin, in one vial for subcutaneous injection, offer the faster and less invasive method for administration compared with the IV formulation, has a similar PK findings, and the serum tough levels and the incidence of adverse events were comparable to those seen with the IV formulation, even when we switch from the IV to the subcutaneous formulation. And very importantly, the most important thing that the tissue-specific pathological CR are almost identical between the IV and the subcutaneous population in the intent to treat population, and we are seeing the same in the real-world data also. Next slide. And the majority of patients preferred the subcutaneous formulation regardless of sequencing and felt that the subcutaneous formulation had no impact on the patient and the doctor speaking time. Majority of healthcare professionals also agree with the same, thought that switching from the IV infusion to the subcutaneous injection would be save time and resources, especially in our setting. And Phesgo is now FDA and EMA approved, and other agencies have also approved it for the same indication as the IV formulation with or without concomitant IV chemotherapy. Next slide. So that will be all for mine. Thank you.
Thank you, sir, for the wonderful talk. So we know Phesgo has changed our approach to the patients who have been taking HER2 treatment, and even the acceptability among the patients have improved. So it has worked wonderfully and has shown a greater pathological CR rates compared to only trastuzumab. So thank you. And so I would like to ask you just one thing. Is there any experience of treating tumors less than 2 centimeters with no nodes, though it is in our panel discussion? So what is your experience? Though we know Phesgo or pertuzumab has not been approved for that.
Not yet approved.
Yes.
But there is some data also that even in tumor size between 1 centimeter to 2 centimeter, even the addition of pertuzumab, although the benefit is just around 1.5%, what we call from 92%, if I'm not wrong, to 93.4%. In real world setting, in our setting, I don't think that makes a difference. But yes, data is there, but data is not that convincing or that very commanding to say that for every patient with a tumor size of less than 2 centimeter, we can. But if the patient goes for surgery, absolutely okay. We understand.
Right. Thank you, sir, for your wonderful talk. So I would like to let's move on to next session. So it will be a panel discussion, again, HER2 positive early breast cancer management. So I would like to invite Dr. Kunal Jain, sir. So he's associate professor at the Dayanand Medical College, Ludhiana, at my center. So sir, over to you for your panel discussion, and please invite your panelists.
Thank you, Nitish. Good evening, everyone. Thank you for the invite for this meeting, which is a learning for all of us. So for this meeting, for this session, if I can request Dr. Burhan Wani, Dr. Moveen Mittal, Dr. Deepak Bharti, and Dr. Mukesh Bansal.
Good evening, sir. Good evening. Good evening, Nitish.
Good evening, sir.
Good evening.
Very good evening, Dr. Kunal.
Good evening. Okay, great. So everyone is here?
Yes.
Deepak is also here?
Yes, sir, I'm here.
Okay, great. So I think Dr. Davinder has already made some part of this discussion clear and easy for us. But over the next few minutes, we will just discuss a few other things about HER2 positive breast cancer. So a couple of cases covering kind of all the scenarios from neoadjuvant, adjuvant, as well as metastatic setting. So the main disclaimer is that most part of this, the content of the slide is provided by Roche. So without wasting time, we'll just start with the first case. Let's name her Mrs. X, with a 58-year-old, who's a 58-year-old lady, multi-para and previous history of menarche 12 years and first childbirth at 24 years. No other comorbidities and no family history of malignancy. She presented with the history of feeling on her right breast, and at the outset, at her first presentation, her fear, you can say, or her choice was that she would want to avoid mastectomy at all cost. And clinical examination showed a 3 centimeter mass in the right breast, with investigations showing mammography showing speculated lesion the right lower outer quadrant, and supported by ultrasound, which also showed a lymph node in the ipsilateral axilla, which was suspicious for disease. There was loss of fatty hilum, and MRI was also done, which also showed this lesion with the suspicious node. And so from here on, maybe we can start with Burhan. Has been part of kind of this discussion recently. So I will not ask about MRI to you, Burhan, but what kind of metastatic workup or other workup you would want with this information? What else do you want?
So the patient is having a sort of node positive disease on the basis of the local imaging that we have till now. So I will be like to have for distant metastasis in the node positive, I would like to have a PET CT in this patient.
Okay. Great. So PET CT scan in terms of workup, and anything else?
And besides, definitely the biopsy of the lesion, that will be the true cut, and to send it for the IHC markers, ERPR HER2 status along with Ki67. That will be the starting phase.
Okay. Okay. Dr. Mubin, anything else?
Definitely, cost is not an issue. Then definitely I will go for the PET scan. And if cost is an issue, then we can have CT abdomen also.
I think for this next 40 minutes, don't think about the costs. Imagine that the patient can afford anything and do whatever you are unable to do, you can do.
Definitely, I will go for the PET scan.
PET scan. Okay. And MRI, do you normally do MRI?
Yes, sir. Yes, sir. Bilateral breast MRI.
For patients who have at 59 with mammogram for confirming, like mammogram showing findings of malignancy.
No, then there is when there is suspicious lesion on the mammogram, then definitely we go for MRI, contrast enhanced bilateral breast MRI, and that's it. This is the normal usual protocol in our hospital which we are following. In this case, MRI breast was done. That is showing the suspicious lesion, and biopsy was done. And I think it's a clear case of CA breast with the HER2 positive. After metastatic workup, we can start the treatment.
Correct. That will come to the biopsy. I have not yet disclosed the biopsy here. So this is showing the MR was done, but I would say in somebody who wants a breast conserving surgery, yes, if you are looking for other multicentric disease, that is one possible indication for doing an MRI. But if you are doing a PET, maybe some smaller lesions will also be picked up. So multicentric lesion, but otherwise routinely, at least in our center, we are not doing MRI for all patients with breast cancer. Okay, so this was the mammogram, which was showing this lesion, which is highlighted, dense lesion, and ultrasound also showing, and this was on the MRI. You can see here this lesion, which is appearing quite dense on the right, in the right breast. And biopsy from the right breast showed it to be IDC grade 3, which was ER/PR positive. HER2 also positive 3+ by IHC, and Ki67 of 50%. So Dr. Deepak, would you do FISH in this patient? Although it was mentioned that FISH was done and got positive. If IHC is 3+, would you do FISH?
No, sir. We are not doing routinely FISH, even if IHC 3+ is there. But sir, two things is there. I want to discuss prior to what they are not discussed, that we have to routinely we are doing FNA of the axillary node also.
Yeah, we are. That was we are going to ask what are the other tests you are going to do. So you want to do FNA from the axillary node.
Node, and obviously we have to discuss with the surgeon, and obviously patient want BCS, and we do clipping routinely in our cases in both the things.
Right. So if BCS is planned, there has to be some pre-treatment maneuver for them to identify the tumor bed. Because why do you want to do that? Because there is a high chance, almost 2/3 of your patient will have the complete disappearance of the tumor when you are giving optimal neoadjuvant therapy. So clipping and ideally biopsy, or definitely minimal is the FNA from the axillary node. We are also doing it not routinely biopsy, but FNA because PET is not the ideal. If you go by the PET, it may both miss the lesions. It has and it can also pick up false positive nodes also. So, Dr. Mukesh, at your center, what happens to such patients? Who do they present to first, and how are they managed?
They can present both to the medical or the oncosurgeon, and then the patient is discussed in the tumor board. And if patient is HER2 positive, then going by the guidelines, we go for the neoadjuvant therapy. We have a detailed discussion with the surgeon, physical examination, detailed drawings of the patient, because as we know, the tumor can disappear if the patient wants BCS, breast conservation surgery, and PET CT scan, FNA from the axillary node, and all these things, the neoadjuvant systemic therapy, and mostly double anti-HER2 targeted Tras2 plus pertuzumab with chemotherapy.
10 patients present to the surgeons, all similar 10 patients, all of them come to you for neoadjuvant?
Yes, sir. If the patient is HER2 positive, I think if patient present to the oncosurgeon, sir, they are coming. Sometimes they present to the general surgeon also, and then sometimes there becomes an issue.
What about others? I think this patient otherwise, she wants breast conserving, but otherwise also with a 3 centimeter lesion, they can upfront do a breast conserving surgery for her also.
Yeah,
So,
sure.
Dr. Burhan, at your center, I believe now you have an oncosurgeon.
Yeah, I think prior to having an oncosurgeon at our facility, the problem that we faced was many a times these patients used to get operated on a FNAC only, did not have even a biopsy, a true cut, or even a receptor status. So there was a very few, you can say, idea about actually how the receptor status is going to change the treatment planning in a particular patient. But with the availability of oncosurgeon at my center now, whether I seeing the case or the oncosurgeon seeing the case, the biopsy is must, and based on the biopsy and the receptor status for the IHC, we decide about the further planning in a patient. That is being, but it is a common scene. I cannot say that this is not a common scene. We still are facing the problems as far as many a times patient getting just some lumpectomy done, even margins are not addressed, even axilla is not addressed, no IHC concept. That is still a problem, and I should awareness is a more important thing once, because we know that breast is coming up. It is a common malignancy in the females, and it is such a thing that we should be upfront. Once we will know about everything, we can plan it in a better way.
Correct. I think patients who present to their primary caregivers or surgeons in periphery, they do undergo initial surgery, which may be incomplete, but these have to be dealt very tactfully, and awareness obviously is the key. And their optimal training has to deal with these patients, so that if they can operate very well with all the under all the guidelines and do a good surgery, then yes, but otherwise they need to be sent to a higher center, because otherwise patient will end up having 2 surgeries, one lumpectomy and then second stage surgery for axilla as well as for margin clearance.
I just saw today a patient who was actually had a lumpectomy, margins were positive, and the axilla was not addressed. So that is a problem. We keep on seeing this sort of a thing in our practice.
Yeah. So, okay. So, Dr. Mubin, so how would you or your surgeons define patients to inoperable? Since you mentioned all patients are
trained medical oncologist or trained oncologist is to be there. They should be aware that TNBC and HER2 positive cancers are aggressive tumors, and in this case, in early breast cancers also, role of neoadjuvant chemotherapy is there. In usual practice, if the patient go to general surgeon, then definitely he will do lumpectomy and will not address axilla. After that, he will come to know that margin are positive, axilla is also positive. Then again, patient has to go multiple surgeries. Definitely issue is there, sir.
Yeah. So when do we call them inoperable completely? I think when the usually now, if I have to say it bluntly, I think all patients for surgery, they are operable unless they have multiple, it's kind of a inflammatory breast cancer. They are unable to get any margin. they can possibly operate on all the tumors. But as you pointed out, two scenarios, HER2 positive and triple negative, definitely should be considered for neoadjuvant. So what is your goal when you are giving neoadjuvant treatment? What do you want to achieve?
Definitely, sir, PCR is our goal.
And what percentage of patients do you think with HER2, this patient, what is the likelihood? What will you tell her before giving neoadjuvant therapy? What is the likelihood?
Then definitely, sir, we will explain the patient. Then definitely, if we'll go for the neoadjuvant chemotherapy, then after surgery, we will get negative margin. Means PCR will be better and chances of the recurrence will be lower in this case.
In your practice, when you are giving neoadjuvant treatment, what percentage of patients, if you have given to 10 patients, let's say, what percentage of patients will get PCR?
Sir, actually, in my practice, I have given till date, I have used double HER2 neoadjuvant chemotherapy in 5 to 6 patients only. And in that, approximately 5 patients got a PCR. But according to literature, approximately with the double HER2 blockage, we can have the approximately 30 to 40% patients have the PCR rate.
Okay, so you have in fact got close to 80 to 90% of PCR.
Yes.
In so good.
Yes.
I think literature will come to that as well. So others, what are your thoughts? So Dr. Deepak, what do you think is the PCR rate that you are achieving in your patients?
So there are two things regarding that. First is the clinical status. That where the patient we are dealing with N2 or N3 disease, obviously there's less chance of getting PCR, and lower the disease burden is there, obviously more chances there. But in my practice, I have seen 40 to 57 patients of getting PCR in the last 2 years.
Roughly 50% patients get PCR.
Yes.
Anything different, Dr. Mukesh?
Sir, I think I am mostly using single anti-HER2 only. In only few patients I have been able to use double. With single, I think around 40 to 50% PCR rate is there. With the limited experience with the double anti-HER2 targeted, I think around 60 to 70% PCR rate is there.
Yeah, correct. So any patients that you would send for surgery first?
Sir, patient with the ER/PR positive and HER2 negative, if they can be operated, I think surgery is the best thing for them. In HER2 positive and TNBC, if it is node positive, then surely neoadjuvant should be offered to them first. In T2 and 0 disease, I think we can have a discussion with the patient preference and oncosurgeon.
Right. So I think other things were already mentioned. So this is the treatment schema usually that everyone is following, and this is what we have been discussing over the last few minutes. If patient is HER2 positive, early breast cancer, no evidence of METs, size is less than 2 centimeters, these are the patients are node negative, they can be considered for upfront surgery. And if it is higher size, more than 2 centimeters or node positive, these are the ones who should be considered for neoadjuvant therapy. Whether you use single or dual is the gold standard that you want to give, because you want to maximize the chance of PCR. And what we need to determine beforehand is also, if there is no PCR, what are we going to do? Because that also we should keep in mind in terms of affordability. What are the chances that the patient is going to get further treatment? So this is what neoadjuvant therapy does. It downstages the tumor, and also your goal is basically PCR, which will enhance your chances of survival. Patients who achieve PCR has been shown in many instances that they tend to live longer as opposed to those patients who don't achieve PCR. So what treatment regime would you use, Dr. Deepak?
Yes. So basically, if you ask me, basically I love to use anthracycline in this patient. But basically, what has happened with the data, the anthracycline regime is there, so I will use TCHP in this patient.
So TCHP, but you would also consider anthracycline in some patients.
Yes, in some patients, because if someone is N2, if someone is more than N2 or more than T3, I'll definitely add anthracycline.
Okay, and what regime would you use?
So obviously AC followed by TH, or in some patients, I have used in some patients AC with THP also in one of my patients.
AC 4 and then TH or THP?
THP. No, TH, that's a THP also in one of my patients, and I will see PCR in that patient, because what I think that because patient has to receive anthracycline only once in a treatment. Because if he not receiving this point of time, and what time will come in future that he is not able to take anthracycline again, because in the medicine they won't give it that. But in the more than N2 disease or in more than T3 disease, I will love to add anthracycline. Otherwise, I will in this case T2N1 I will add TCHP only.
Let's hear from Burhan, counter argument.
No, I think what Dr. Deepak has said that about using the anthracyclines. The main reason for using anthracycline, I think we had a discussion some days back or a day back also about whether to use anthracyclines or just to continue with the non-anthracycline based. The problem that we are facing is that majority of our patients, they have the burden of disease is quite high. Even if the local disease, they come with locally advanced diseases. In that sort of a setting, we want to expose them to both the anthracycline as well as the non-anthracycline regimen and get the maximum benefit out of it. And we know the other problem that we might be facing is the probably we may not be using the pertuzumab because of the cost that may be added. So in that case, probably yes, both the things should be added. But I think in this sort of a scenario where there is just a sort of T2N1 disease, I think choosing a non-anthracycline based regimen will be the good.
Right. So I would agree. I think if there is high disease burden, and especially if the patient is unable to afford pertuzumab, then that is the scenario where I tend to use anthracyclines to optimize the treatment, and using 4 cycles of anthracycline base and then 4 of taxane with. So this patient got 4 EC followed by weekly paclitaxel, which was combined with pertuzumab and trastuzumab. And these are the 2 studies which are not designed for mainly looking at PCR, but what we got from PhD, it was about 40%, and TCHP was a maximum which gave 364%. And regime, there are only 3 cycles of anthracycline. In fact, regime 3 cycles were used, and it gave a PCR rate of about 57%. So after neoadjuvant therapy, there was significant shrinkage evidenced on the imaging. We need to do the same imaging which we do before, just to document what is the size. And this basically shows the different PCR rates that we get with various regimes, and maximal is with the TCHP, which is close with the FAC and pertuzumab and dual. So we have all discussed train 2, which basically showed that even if you do not give anthracyclines, without anthracyclines, you can achieve the similar kind of PCR rate. So, and 3-year EFS and EOS were the same. So, Dr. Mubin, here the patient had this neoadjuvant chemo, and after surgery, she had a breast conserving surgery, but the histopath showed there was a residual disease of about 7 mm with grade 2, and lymph nodes, axillary nodes were negative. Only 4 were removed, and they were negative. It was ERPR positive, HER2 positive again. So, any comment on this report and your treatment plan?
Definitely, sir. I will go with the TDM1. When there is residual disease and after surgery, PCR is not attained, then definitely I will go for with the TDM1.
Okay. And Dr. Mukesh?
Yes, sir. If the residual disease is there and cost is not an issue, then obviously TDM1 for the remaining of the cycles.
And again, routinely, do you do these markers again after surgery?
Yes, sir. Routinely, we are now doing all these markers post surgery also, because there is some discordant rate around, I think, 5 to 10% in
What will you do if HER2 is negative? What do you do if HER2 is negative?
Sorry, sir?
If HER2 is negative, what will you do?
Then I think it
will confuse.
It is a tricky, confusing thing, but depending on the other things like Ki67, the load of the tumor before surgery, we try to divide into a luminal ABC class, A, B, and this classification, and tend to continue with the trastuzumab if we think Ki67 is high, tumor load is high. But in some cases, after discussion with the patient, we can forego the anti-HER2 if we are convinced that it is entirely HER2. But this is a topic of discussion, not a clear-cut answer.
Dr. Deepak, you have any thoughts on this?
Nothing like that. I have not encountered this thing at present and not heard of that. I think you will enlighten us. Have you faced this thing in your future?
Burhan?
Sir, again, I think we have been repeating the same thing yesterday, what we discussed. It is about actually more of confusing the things. Yes, as you mentioned yourself yesterday, that there are clones of cells where there may be from positive to turn to the negativity. But the problem is that I still feel that we will not change our treatment even after that. We will continue what we are giving. Only thing that will decide is
anti-HER2 therapy. I think if the patient, we cannot change the status of luminal AB post treatment. It is luminal B beforehand, so it will remain luminal B, and we will give adjuvant Kadcyla. That will be the ideal choice. But as I mentioned earlier also, there are some thoughts if the patient turns HER2 negative on biopsy, then, and if they have not received anthracyclines, one school of thought is to give them anthracyclines. But again, it is not the standard of care. The standard of care would be anthracycline, Kadcyla with radiotherapy, and you would also give hormonal therapy. So any thoughts on adjuvant use of pertuzumab? We can quickly just vote, starting again with Burhan. Do you use adjuvant pertuzumab after surgery? Patient has not received any neoadjuvant treatment, upfront surgery, and HER2 positive.
I have been using especially for node positive disease. Node positive disease I have used, and there is a data to it. Especially if we see the affinity trial, they had shown a very good data of adjuvant dual anti-HER2 therapy. So based on that, definitely yes, I'm using. But normally, what we used to do, at least if we had to give the pertuzumab, I used to give in the neoadjuvant setting just to achieve the pathological complete response.
I would also concur partially. I think the data is there, affinity, but it is not a very strong data. And there is a IDFS advantage of about 4-5% with such an expensive drug. So we really do not know which, but yes, if it is 4-node positive, that is the indication where I generally offer adjuvant pertuzumab also to patients who can afford it. So Dr. Mubin, what about your thoughts on Phesgo? Wherever you are using or you were using pertuzumab, are you replacing all patients to Phesgo now?
No, sir. Actually, I am using the trastuzumab and pertuzumab separately. We are not using a combination of Phesgo. Actually, in the adjuvant setting, I have not used pertuzumab till date because mainly we have the paneled patient. It's very difficult to explain the justification for the pertuzumab in the adjuvant setting in HER2 positive patients. And second issue is if the patient is node positive, more than 3 to 4 nodes are there, and it's a very costly medicine. And it's very difficult to explain the justification of the pertuzumab in the adjuvant setting. Till date, I have not used pertuzumab in the adjuvant setting in any patient.
So why IV pertuzumab?
Sir, because of availability, I think Phesgo people has not reached till Patiala till date.
Okay. Dr. Deepak?
Yes. So there are 2-3 questions regarding that. I just want to discuss 2-3 points. Basically, initially when Phesgo come into the market, I am very much into the IV pertuzumab. But what we discussed that in the metastatic setting, I am allowed to add Phesgo, but in the neoadjuvant setting, I am still using IV. But in the last 7 to 8 months, the confidence on Phesgo we have gained that we are not seeing so much side effect that we are seeing with diarrhea, a lot of diarrhea with IV. So I am shifting my patient to neoadjuvant setting also with Phesgo. This is one point. And regarding adjuvant point, that your point is right, that more than 4 nodes are there, more than bulky disease is there, we will add adjuvant pertuzumab, otherwise we continue with a single trastuzumab only.
Okay. And finally, Dr. Mukesh,
Sir, I think I'm using Phesgo, sir. The only issue is if the patient is too much underweight or too much obese, because in Phesgo we have the fixed dosage schedule, and especially if we have to give neoadjuvant to this not average based weight based adult, then I am using IV. Otherwise, I think Phesgo is convenient. I have used. I have not found any significant
What
issues
is your
with it.
concern in both the settings, in underweight and overweight? What is your concern?
Sir, in overweight, I think the dosing basically, because the pertuzumab and trastuzumab, we have to give with this 8 mg per kg and loading, and then 6 mg per kg. In Phesgo, depending on the weight of the patient, it can be either too high, leading to more side effects and more wastage of the drug, whatever, more pricing also. And in the other setting, it can be the underdosing also.
I think Federica study was just discussed, and it showed that patients who were underweight, the number was very small. It is only 10 patients who were underweight. This is the Western data. So our patients mostly will possibly be malnourished, and they had inferior response with Phesgo, which is surprising. You would expect if you are giving a higher dose, you would get a higher response, at least in underweight. But those patients got almost 50% PCR with the Phesgo, which I don't know the explanation. And if you see the Lancet Oncology paper, they also do not mention any explanation. And overall, they have mentioned there was no significant difference in under or overweight. And concern about toxicity, that is kind of well answered. There was no extra toxicity, cardiotoxicity with the underweight patients also. And so I do not really have the answer, but yes, I would be a bit skeptical in using in underweight, whether it is due to the less fat content, which is kind of needed for subcutaneous formulation, for penetration, and subsequent their area of curve. I do not have the answer, but that may be the reason. Maybe Roche people will be able to answer, or further studies need to be done in that subsequent population. So we'll just quip. I think this has already been discussed, and it is patient conveniences there. And I would also say there are more patients and concern. You mentioned about, interestingly, you mentioned about cost, which is dose wastage and higher cost. So in fact, it is a cost saving maneuver, I would say, with Phesgo, because it is at the same cost of pertuzumab, and you are getting innovator trastuzumab free of cost for whatever time you want to use. So cost, I would say, is not a concern. In fact, cost is in favor of using Phesgo. But yes, dosing, we have been trained to use the dose weight-based trastuzumab, and now suddenly this drug comes and it says that you use flat dose of trastuzumab. So we were possibly doing everything wrong earlier, or I don't know, this is wrong. So, but yes, we are getting good PCR rates with the use of neoadjuvant Phesgo also. Nitish, you have any comment?
Yeah, definitely, sir. Those were the outliers in the Federica study. The people who the number of patients was less in the population who were underweight, and even the overweight population certainly had a lesser response compared to the normal weight or average weight population. So otherwise, it is a fairly good and acceptable drug. Only thing I have in mind, like there is two school of thought when we are prescribing anthracycline-free regimen or a anthracycline-based regimen in HER2 positive. Do we target the patient with the target therapy earlier? I mean, I tend to do that. We give the target therapy earlier and see the response. If she's not responding to that drug in a good way after 3 to 4 cycles, tend to change it to anthracycline. Otherwise, it is always better to give the upfront a target therapy so that we can achieve a better PCR rates. As the trials TRAIN2 and Trifina has also shown that anthracycline-free regimen shows almost equal over PAT-CR rates.
TRAIN2 used anti-HER2 dual anti-HER2 with anthracycline, which I have not done. And
maybe, sir, I would like to say there is no, I mean, there is some the Trifina they have shown but still there is no such concrete evidence to omit the anthracyclines, even if the patients who are whatever means we are discussing right now. So
High risk
clinically
loading.
T2 or T3 with N1 and 2 means there is no such data to omit anthracyclines. Definitely, I would like to go based upon the patient to patient, some cardiac status, or means even which is HER2 therapy is also a contraindication if the anthracyclines are. So means if you think the patient cannot, means cardiac status is okay, but frail status may not be able to tolerate the toxicity of anthracyclines, means like neutropenia, that is one of the things. Otherwise, means I will be of opinion not to omit the anthracyclines.
Yeah, so not for all, but yes, I agree. And we will be only giving 4 cycles of trastuzumab before surgery in these patients, or anti-HER2. So that is the other thing.
Sir,
Where we
the
will
other
take-
thing which Nitish was saying, that if you are going to give with the THP, you can give 4 to 6 cycles. And like in that Catherine trial, they have used even THP 4 to 6, and they are given that anthracycline post-surgery also. They have used some 3-4 different
Not in
institutions.
post-surgery. Catherine used 72 or 75% of patients received anthracycline before surgery. Catherine randomization was a PCR or non-PCR.
Yes.
So there almost 3/4 of patients received anthracycline-based regime.
Yes.
And only 25 were anthracycline free. So I would say it is not that we can completely put the anthracycline in the basket and we cannot use it. It is case to case.
It is just a case to case base, because you have to choose and you have to go with
Just moving quickly with the last case, one quick comment from everyone. A young 40-year-old patient with metastatic breast cancer and with lung bony mets, ER positive, HER2 positive, and HER2 3+. So what would be your choice of treatment, Dr. Burhan?
So I will be giving a dual anti-HER2 therapy with a taxane. So that will be my choice in this patient.
Okay. And what dual anti-HER2, Phesgo or IV?
Phesgo, you can say that I have used for only one odd patient in over the past, you can say 1 month. So it was the first patient I have started on Phesgo. But yes, definitely, I think with the data that is coming up, I am now a little more convinced in giving Phesgo, and that is easy to be administered and cost effective as well.
Dr. Mubin?
So definitely I will go with the Cleopatra regimen, trastuzumab, pertuzumab, and taxane.
Okay.
Definitely, cost is not an issue, and that
Phesgo is available in Patiala tomorrow. Then
that is, if Phesgo is available at my center, that definitely I will go with the Phesgo.
Right. Okay. Dr. Deepak, your choice of treatment?
The same as THP plus bisphosphonates.
Okay, THP with bisphosphonates. And last, Dr. Mukesh?
Sir, taxane plus trastuzumab plus pertuzumab.
Yeah, and no reservation in using Phesgo in such a
No, sir.
situation?
No, sir.
No, sir, we use Phesgo.
If we are looking at a longer usage of this drug, if your DFS is, let's say, 18 months, 1.5 years, after 1 year, Phesgo will be free. And your trastuzumab is also free from. So cost effective, I think definitely it is there. Now issue is only about certain populations where it may be possibly less effective, which we do not know the answer as yet. So I think with that we will end, and I think time is also up. So thank you very much to all the panelists and Nitish and Jagdeep for his comments. Thank you very much.
Thank you, sir.
Thank you, sir. Thank you for the wonderful discussion of these 3 cases. So next, moving on to the breast cancer management, early breast. So the last topic is on the triple negative part of it. So I would like to call Dr. Jagdeep sir for his talk on management of early breast cancer in triple negative setting with the role of chemotherapy and immunotherapy in this. Over to you, sir.
Thank you, Nitish. Thank you for giving me this opportunity and this lecture in this CME. So I'll be taking now to this chemotherapy and immunotherapy in the NACT negative, triple negative breast cancers. My screen is visible and I hope it's moving.
Yes, yes.
Yes,
Thank
sir.
you so much. So with that, so this is a graph showing in different studies, that is GPAR6 and CALGB and ADAPT and brightness and other NeoSTOP studies, which have showed the patient who received the neoadjuvant chemotherapy, they have a better PCR rates as compared to the patient who are not have received the neoadjuvant chemotherapy in the form of carboplatin along with the anthracycline base plus taxane. So they show that carboplatin has some added benefit to the patient who received this NSCT, and the PCR rates were better in those patients. So if you see all the pink bars, the carboplatin addition to them as compared to the green bars, that I showed that there is certainly a difference in those. So this just going to the same thing, that addition of the carboplatin to the neoadjuvant chemotherapy in the patient with a triple negative, and of course there was seen a complete more of the PCR rates, and definitely this was a surrogate marker for the overall survival and the patient who achieved this PCR, and that improves in the overall survival was also there. And that's what based on one of the meta-analysis as were done from the All India Institute, New Delhi. So the other studies which showed that the neoadjuvant chemotherapy, they had a better outcome when given to the patients who are triple negative, and there are different phase 2 and phase 3 studies. And if you see in those the patients, the primary point was basically the complete pathological response rates, and it has pointed in all these studies, the patient who achieve this PCR, they have a better outcome and better overall survival rates. So if you see in this forest plot also, the studies, it has shown that the patient favors the neoadjuvant chemotherapy in addition of the carboplatin to the anthracycline and the taxane based chemotherapy. So all the different studies done in different timelines, they have shown the patient who received the neoadjuvant chemotherapy, they do better as compared to the patient without that. So say this is same in continuation, the patient who are getting this carboplatin along with the other chemotherapy backbone, they have a better DFS and they have better overall survival rate.
I think there is some connection issues. Let me talk to Dr. Jagdeep for if we'll be able to continue, or we can ask Dr. Priyansh.
I think
okay,
some
sorry.
okay.
Okay.
There, so I was already
okay. Okay. Great. Sir.
So definitely the patient who received the neoadjuvant chemotherapy along with the carboplatins, and they had a better outcome and the better PathCR as compared to the patient who received that other drug of that is anthracycline and the taxane-based chemotherapy. So different studies, I just pointed on this. If you see this forest plot, they have clearly favored that the patient who receiving this carboplatin in the triple negative, they do tend to better as compared to the other patients who are getting the standard of care. So if you see this one of the study and TMC neoadjuvant platinum based TNBC, the patient who were randomized to either the standard of care, that is paclitaxel and or AC or EC, and with the addition of carboplatin, and they underwent surgery and then followed by the radiotherapy. The control arm was basically the standard of care, that is a taxane plus AC or EC, and the study arm was addition of the carboplatin to this taxane along with the AC or EC. So basically the patient who received this chemotherapy, they can opt for either BCS or for the mastectomy as their own discretion. And the results were that the study approval was from that April 2010 to January 2020. And approximately the patient in the intention to treat analysis was 770 with a median follow-up of 67 months. And if you see the characteristic features in both the control arm and the platinum arm were well matched as compared to in comparison with the age, or whether their menopausal status or the family history of any cancer. So whether what patient was operable or it was a locally advanced and node negative or node positive, and the clinical size of the tumor. So all these parameters were well matched in both the arms of this study. So when we see to the result of this day in the intention to treat analysis population, the pathological response in the patient who received the neoadjuvant, the treatment arm, that is that who received the carboplatin along with the standard of care, you see the PATH CRU comparing of the either nodes or breast or in total of both breasts and nodes is a much more better as compared to the patient who are getting the standard of care. And it was shown to be a statistically significant. And if you see the patient who, if you're talking about both breast and nodes, the difference was approximately 14.2%, the patient who are getting this platinum arm as compared to the controlled standard of care treatment. Similarly, with respect to age, if the patient who are less than or equal to 50 years of age, they tend to do better as compared to the patient who are more than 50 years of age. So these are the one of the evidences when the patient is having young, which we always consider a high risk patient. Triple negative itself another high risk feature. And definitely neoadjuvant chemotherapy in the triple negative breast tend to do better in the patients who are getting this carboplatin in addition to the standard of care. So that age, if you take into consideration, definitely do better in the premenopausal. Sorry, in the patient less than 50 years of age. So in the event-free survival in the intention to treat analysis patient who received the neoadjuvant chemotherapy, it is approximately in the platinum arm, it was 70%, and in the control, that is standard of care, it is 64%. So with a difference of 6.6% in patient who are getting additional of this carboplatin to the standard of care. In the patient who are younger and older, if you see the patient who receive the platinum, the difference is close to 12.5%. That is the patient who are young in age, they have a better PATH-CR and they tend to have better EFS. So that was approximately 20%, and that's again close to 12%, the patient who are less than 50 years of age. In case of patient who are more than 50 years of age, they also show some difference in the event-free survival, but that was not a statistically significant. That was 62% as compared to 69.3% patient who are getting sorry, the patient does not tend to do better with the platinum as compared to the patient who are getting the control arm. So basically, age is one factor which may be considering when we are planning treatment, that carboplatin can be a better option in those patients who who are triple negative and who can get this along with the standard of care rather than giving only paclitaxel or docetaxel. Similarly, if you see the event-free survival subgroup analysis, this forest plot shows the patient who received this platinum in comparison with the standard of care, they tend to do a better. And in case of age or in case of menopausal status or a family history of cancer or any other clinical stage, majority of the factors they favor of the addition of carboplatin to the standard of care. In only that is the age more than 50 and then the post-menopausal, that may not be a beneficial in those. But all others, the factors they favor that the addition of carboplatin will be better choice and the patient who getting this in the triple negative. So overall survival in the intention to treat analysis population, that was approximately 74.4% patient who are getting the platinum arm as compared to the standard of care, which was 66.8%. So again, this was statistically significant and the difference was 7.6%. In the patient less than, again, 50 years of age, this difference was again even more, that is approximately 11.2%, that the patient who are getting the platinum, that is was 77% as compared to the control, that is 65.9%. And again, it was statistically significant. But in the patient who are getting over this treatment, that is a standard of care along with the platinum, and age is more than 50 years of age. So if you see in those, The platinum arm and the control arm are almost similar, that 68% versus 68.9%. And again, it was not a statistically significant. So if you take all this EFS and overall survival, this age plays a very critical role if in deciding that patient who are getting a carboplatin, the triple negative, they will tend to have better EFS and OS in those patients. Similarly, this overall subgroup analysis, if you say again, that in case of age less than 50 years and pre or perimenopausal, these were statistically significant, though the family history of cancer or clinical stage, they are showing some benefit, but they were not statistically significant in the patient who are getting this platinum along with the standard of care in comparison with the standard of care. So if you ask for the prognostic impact of this pathological response, you see the patient who achieved this PCR as compared to the patient who does not achieve PCR, the event-free survival rate at 5 years was statistically significant, and the difference of approximately 33%. In the patient who got this PCR, they tend to do much better. That is, 5-year EFS was 85% versus 52% patient who does not achieve a PCR. So this figure is a statistically significant, which can show that the patient who are young in age and who are premenopausal, and if they are given a carboplatin along with a standard of care, and if they achieve a PCR, there will be a much significant difference in the event-free survival as compared to the patient who does not achieve a complete PCR. Similarly, in the patient with the older age, as compared to patient, if you see that in the younger and older, we have just seen that the patient who are less than 50 years old, they do tend to better. But if you see with the patient who are again more than 50 years who achieve PCR, they also tend to do better. Otherwise, the patient who are older age, they were not doing better as compared to the patient who are less than 50 years old, but who achieve PCR, they are still better and they have a better EFS as compared to the patient who does not achieve a PCR. So if you take this study of TMC, so that the addition of this carboplatin to the sequential taxane and anthracycline NSCT, this significantly improve the overall survival and tend to improve the EFS among the patient who are the operable or locally advanced TNBC. This benefit seem to confine more to the younger or the premenopausal patients in whom there is substantial and significant improvement in the event-free survival and the overall survival. And this increased PCR along with the addition of this carboplatin is a predictive of the EFS and OS benefit in the younger patient, and the lack of improvement in PCR is predictive of lack of the EFS and OS benefit in the older patient. So this was regarding the addition of carboplatin to the standard of care in the patient with triple negative. So this is one of the immunotherapy, pembrolizumab, in the early breast cancer, that is a keynote 522 study, which has shown that the addition of this pembrolizumab to the triple negative patient, early breast cancer, and given in the NSCT followed by surgery and for 9 cycles in the adjuvant setting. So the patient who received this neoadjuvant chemotherapy, carboplatin can be in the paclitaxel can be in the weekly or can be in the 3-weekly form, followed by the anthracycline, along with the addition of pembrolizumab in both, that is paclitaxel carboplatin, and in the second anthracycline based chemotherapy. And then this is the surgery, advice to do surgery, and then to the pembrolizumab arm in the adjuvant setting. So if you see the characteristic features of these again were well matched in both arms, and the studies showed that patients who received pembrolizumab combination along with the chemotherapy as compared to the chemotherapy alone, they tend to do better, and there is a major reduction in the distant recurrence in the patients who are receiving this pembrolizumab. And the event-free survival at 3 years was again a significantly different, that is 84% the patient who are receiving pembrolizumab as compared to the 76% patient who are receiving only the chemotherapy. So the thing is that once you give this chemotherapy along with the pembrolizumab, So what if you don't achieve the PCR, and what's the role of this adjuvant pembrolizumab? Is going to improve the EFS or the overall survival? Or if the patient is a triple negative and you have having olaparib, said there's germline BRCA mutation positive, whether addition of olaparib will improve the outcomes in the patient who are getting this adjuvant pembrolizumab? Because when the time this keynote study was started, we don't have the result from the CREATE-X trial, which showed that the patient who are triple negative, capecitabine is one of the drugs which can be given patient who have the residual disease, and whether different NACT regimens can impact the outcome. And the other thing, most important, what is the outcome of the patient who are receiving this pembrolizumab after the chemo completion? Suppose that does not achieve this PCR, and just with a single agent pembrolizumab, are they going to have better EFS, OS? That questions are still unanswered. So with this, I conclude my session, and it is open for questions.
Thank you, sir, for the wonderful session. So definitely we know like NACT in the triple negative has done a wonderful thing, improving the PCR rates, and along with that addition of carboplatin, which we initially tend to use a dose-dense chemotherapy regimen. Now the patients who don't tend to respond in that, we tend to add on carboplatin, or upfront itself we can use carboplatin based regimen. So definitely addition of immunotherapy has its own benefits. Improvement in the overall survival with the improved PCR has been there. But again, the questions are unanswered, because what to do in the adjuvant setting in case we don't achieve a PCR, as you rightly pointed out.
That question is still not answered, whether addition of this capecitabine to the pembrolizumab, as when we see if a NACT combination of chemo plus IO can give a better PCR, why not to use this capecitabine as an adjuvant along with the IO, which may be a better outcome if it has improved the survival in the patient who has invasive disease following NACT. So that could be one thing. Other thing, if you see this in this keynote 522 trial, that is the standard of care arm, that is paclitaxel carboplatin, that is same what TMC has used. That's addition of carboplatin could be better option rather than if the patient is not affordable for the, and the difference is close to 8 to 10%, if I'm not wrong, the patient who are getting this IO along with the carbotaxel. So if the patient is still going for a new urgent chemotherapy, definitely give carboplatin along with the Taxol in the NAC setting if the IO is not affordable. And the patient who are planning for IO, that PD-L1 status is irrespective. Either it's a PD-L1 positive or negative, does not make any difference in the outcomes. Rather than PD-L1 negative, they had a better hazard ratio as compared to the patient who are PD-L1 positive.
And also another thing is, during the CREATE-X trial, we did not have the data of addition of carboplatin with the neoadjuvant chemo.
So that's why I said the NACTs are different in two different settings. In the TMC trial, in the CREATE-X trial, and in this keynote 522. It means difficult to compare two or three different trials in between them. But definitely it will not be answered also, whether addition of this capecitabine, that whether mask the effect of adjuvant this pembrolizumab, and they will not be ready to do that trial also.
And even addition of olaparib to pembrolizumab.
So a lot of things are answered. I mean, initially when we were discussing regarding abemacicillin, when we were having that marginal difference and the patient is germline BRCA positive, whether addition of olaparib is better or addition of this CDK4/6 in the adjuvant setting, this is still not answered. So we don't have that things in that.
Right. So thank you, sir, for your wonderful talk. So next, I think, thank you, sir. I think it will be our last session. I would like to invite Dr. Priyanshu Chaudhary. He's a consultant medical oncologist at Shelby Hospital, Mohali, for his talk on role of PARP inhibitors in the adjuvant setting in early breast cancer. Dr. Priyanshu, I would like you to take over the session, please.
Thank you, Dr. Nitish. I think so. My talk has a little bit of the topics which we were discussing just now, so I won't be. I didn't intervene at that time. So can you please share my slides? So a very good evening to everyone, and because it's the last session, so I won't be taking long. So my topic here today is PARP inhibition in adjuvant setting in breast cancer. Next slide. So we all know that PAT-CR improves overall survival in patients with breast cancer. Those who have a PAT-CR tend to do better. So if we see here, overall survival is better in patient in both TNBC versus non-TNBC, in patient who achieve a PAT-CR versus who don't. TNBC by default is a poor prognostic factor, and in patient who have a residual disease and who are triple negative, so they fare very badly, as we can see in this red graph. Next slide. So coming to the incidence of BRCA mutation. So BRCA mutations are the most common genetic variants in breast cancer and are associated with an aggressive clinical and biological features of breast cancer. So the incidence in hormone receptor positive, HER2 negative early breast cancer is approximately 10%, while a triple negative early breast cancer is around 10 to 20%. The prevalence differs by ethnicity, race, and age. Next slide. So BRCA mutations, BRCA1 and BRCA2 proteins support the timely and accurate repair of the double-stranded break, and they help maintain genomic stability. BRCA mutations inhibit the repair of DNA double-stranded breaks by homologous recombination pathway, resulting in genomic instability. Next slide. The PARP genes encode enzymes that help maintain DNA integrity during replication and repair single-stranded DNA breaks. PARP inhibition leads to synthetic lethality in cells deficient in homologous recombination repair, such as those with BRCA1 and 2 mutations. PARP inhibitors have demonstrated efficacy in BRCA-mutated cancer, including breast cancer. So if you see here, normally the DNA is repaired well, and even with patients who are BRCA mutated. So the base excision repair, the BER pathway, with the help of PARP proteins, they, although the double-stranded breaks are not repaired, but because of BER pathway, the repair is done through PARP. So, but when this also is inhibited by the PARP inhibitors, so both these pathways are deficient for repair, and this leads to defective DNA repair, which leads to apoptosis. So this is known as synthetic lethality. Next slide. So coming to PARP inhibitors in adjuvant setting, the data, which is the Olympia trial. Next slide. So this is the Olympia trial schema. If we see the patients with germline pathogenic or likely pathogenic BRCA1 and 2 mutations who were HER2 negative, that is either hormone receptor positive or TNBC, with stage 2 to 3 breast cancer were taken, and the local genetic testing or on-study central screening was done by Myriad Genetics. So they had two groups, one which received the neoadjuvant therapy and one which had only adjuvant therapy. So the neoadjuvant therapy group, which were included, were triple negative breast cancer with residual disease after neoadjuvant chemotherapy, or hormone receptor positive patients who had a residual disease and which also a clinico-pathological score, CPS plus EG score more than equal to 3. So we'll be discussing the score later on. It varies from 0 to 6. With the higher the score, higher is the risk of relapse. The adjuvant group had triple negative who had either a T2 disease or a node positive disease, and hormone receptor positive with more than equal to 4 positive lymph node, that is N2 disease. So they received the standard treatment followed by surgery and radiotherapy, or the surgery followed by adjuvant therapy and radiotherapy. And then they were randomized 1:1 to olaparib, 300 milligram twice a day for 1 year versus placebo twice a day for 1 year. The primary endpoint was invasive disease-free survival, and the secondary endpoint was distance disease-free survival, overall survival, the incidence of BRCA1 and 2 associated cancer, health-related quality of life, and safety. And they were also stratified according to the hormone receptor status, hormone receptor positive versus triple negative, neoadjuvant versus adjuvant therapy, and prior platinum-based chemotherapy, yes or no. Next slide. Next slide. So if you look at the baseline characteristics, they were well matched. If you look at the median age, this is very important. Median age was 42 or 43 in the two arms. So we all know that BRCA associated cancers tend to present earlier. But the most common mutation here was BRCA1, almost 70%. Similarly, majority of the patients were premenopausal, 62%, and they were well balanced between the adjuvant or neoadjuvant. Almost half of the patients received adjuvant and neoadjuvant. Another important aspect here is that hormone receptor positive HER2 negative disease were only 18.2% in the olaparib arm, while 81.5% were triple negative breast cancers. So almost 3/4 received a mastectomy, while a quarter received breast conservation surgery. Next slide. Next. So these are the high risk criteria. These are very important because if we have to prescribe olaparib, we need to use these criteria for selecting the patients, or even for selecting the testing of BRCA1 and 2 for the purpose of therapeutics. So if we see the triple negative cancers, which were 82% of the patients, if they were treated with adjuvant chemotherapy, they were required to have either axillary node positive disease N1 or invasive primary tumor measuring at least 2 cm on pathological analysis, that is PT2 or more. And if treated with neoadjuvant chemotherapy, they were required to have residual invasive breast cancer in the breast or resected lymph node, that is, there was no PAT-CR from neoadjuvant therapy. And in hormone receptor positive, which constituted 18% of the patient, they were required to have at least, if treated with adjuvant chemotherapy, that is upfront surgery, then they had to have at least 4 pathologically confirmed node, that is PN2. And if treated with neoadjuvant chemotherapy, they should have a residual disease with a CPS plus EG score of 3 or higher. So if we look here on the right side, we can see this CPS plus EG score. It is a clinical pathological score, and E refers as the estrogen receptor status, and G is for grade. So if we see, it has 4 parameters: the clinical stage, points ranging from 0 to 2, a pathological state, points ranging from 0 to 2, receptor status, in ER negative disease, it's 1 point, and nuclear grade 3 has 1 point. So total score can range from 0 to 6. The higher the score, the higher is the probability of relapse, and it indicates a worse prognosis. Next slide. So this is the studies which are which are validating this score. So if we see the DFS in a meta-analysis of 8 trials showed that higher the score, if we see the yellow line, which is a score of 6, and red line with a 5, and gray with 4. So these are doing 3 and more are doing pretty badly, if we see here. Similarly, and the best cancer specific survival in real world analysis also showed that 5 or 6 were the one which had the worst outcome in a real world scenario. So these studies validated that this score predicts the outcome of a relapse. Next slide. So coming to the primary endpoint, which was the risk of invasive recurrence, that is IDFS, in the intention to treat population. The 3-year IDFS rate in the olaparib arm was 85.9% versus 77.1% in the placebo arm. The difference was 8.8% with a hazard ratio of 0.58, which was statistically significant. Next slide. Now the secondary endpoint, which was the distance disease-free survival, and the primary IDFS. This is the updated analysis at 4 years. So we'll look at the IDFS delta, that is around 8.8% benefit in the IDFS versus control at 3 years, and 7.3% at 4 years with a hazard ratio of 0.63. While the distance disease-free survival, again 7% benefit with olaparib at 3 years, and 7.4% at the end of 4 year, hazard ratio of 0.61. Next slide. So the subgroup analysis of invasive disease-free survival also showed that almost all of the subgroup received benefit with this therapy. So I won't be going much into detail. Next slide. Now coming to the overall survival, this was the second overall survival interim analysis. In the intention to treat population, the overall survival was significantly prolonged at the end of 3 years. Olaparib versus placebo, 3.8% improvement in overall survival, 89.8 versus 86.4, hazard ratio of 0.68, confidence interval 0.47 to 0.97, a p-value which was significant, 0.009, crossing the significant boundary of 0.015. So it has both a DFS benefit as well as an overall survival benefit at the end of 3 years. Next slide. So coming to the FDA approval, so FDA has approved Olaparib. It is indicated for the adjuvant treatment of adult patient with deleterious or suspected deleterious germline BRCA mutated HER2 negative high risk early breast cancer who have received neoadjuvant or adjuvant chemotherapy, and to select patient based on an FDA approved companion diagnostic test. Next slide. Now coming to the adverse events, which probably are, for a 1 year duration if you are giving Olaparib. So these are very important. So the most common treatment-related adverse events that led to discontinuation of Olaparib were nausea, 2%, and anemia. So the total discontinuation rate due to adverse events was 10.5% in the Olaparib versus 4.5% in the placebo. Another important is the patient decision, 9.1% versus 4.6%. The rest were all similar to in the both these arms. Next slide. So coming to the adverse events, they were mostly mild and moderate in the Olaparib arm, and they were manageable. So one of the important side effects which we are worried is the risk of second malignancy, MDS and AML. So if we look at this, the chart, actually the rates were numerically lower with respect to MDS, AML and new primary malignancy in the Olaparib arm compared to placebo, while the grade 3 adverse events was slightly higher compared to placebo, but grade 4 adverse events were less than 2%. And as we discussed, around 10% of the patient discontinued treatment because of the side effects. And there was 1 death due to adverse events. Next slide. So the adverse events observed were consistent with the other trials of Olaparib. And so these are the adverse events of any grade occurring in at least 10% of the patients. So the most common were nausea, fatigue, anemia, vomiting, headache, diarrhea, neutropenia, leukopenia, decreased appetite, dysgeusia, dizziness, and arthralgia. So these were any grade side effects, but anemia was the only grade 3 adverse events occurring in more than 5% of the patients. So hematological toxicity, we have, it's a side effect which we all have faced while using Olaparib. But overall, if we see grade 3 events, only anemia was the significant one, which was more than 5%. Next slide. Next slide. So this is the blood transfusions which were required. So almost 5.8% patients required blood transfusion due to anemia. And but the good thing is that only out of these 5.8, 4.1% patients required only 1 transfusion, and around rest almost less than 2% required more than 1 transfusions for anemia. Next slide. Now coming to the health-related quality of life, which is a very important factor, considering we are using it for 1 year. So 1 year of adjuvant Olaparib maintained global health-related quality of life versus placebo, and this was, applicable in both patients who received neoadjuvant chemotherapy as well as those who received adjuvant chemotherapy. Next slide. So the guideline recommended biomarker testing for breast cancer, we all know HER2 as per the ASCO-CAP guideline, IHC plus minus a dual probe-ish assay, ERPR testing by IHC, the gene expression assays to guide adjuvant chemotherapy, BRCA for TNBC at any age, male patient with breast cancer, and those who meet criteria with personal or family history, and when considering Olaparib as adjuvant chemotherapy, Ki67 if considering adjuvant abemaciclib. Next slide. So there's a human tendency to compare. So we'll be also comparing this with other strategies. Next slide. So in triple negative breast cancer today, we have 2 other therapies which we were discussing just now. That is the CreateX strategy and the Keynote 522. Next slide. So capecitabine and olaparib. So, cross trial comparisons are always unjustified. But if we look at the CREATE-X trial, which showed that capecitabine had a 5-year DFS with 69.8 and 78.9% 5-year overall survival. But this trial did not use the gene signature for testing, which was used in the GCAM-SIBOMA trial, which had 876 patients, in which 647 had basal-like, while the rest were non-basal-like. So in this study, the capecitabine benefit was limited to the non-basal subtypes. So this is very important. We routinely prescribe our capecitabine to every patient of triple negative who have not achieved a PAT-CR. But overall, if we see, this trial showed that using the PAM50 gene signature, the patients who had a non-basal subtype, they had the benefit compared to those who had a basal subtype. So, and this, then we had the EA1131 study, in which platinum was compared with capecitabine in patient who had a residual tumor after neoadjuvant chemotherapy. This trial also showed that the platinum was not superior to the capecitabine maintenance post neoadjuvant therapy, and while it increased toxicity, it did not improve survival compared to capecitabine. So unless and until we have a testing method where we can probably use we can classify based on whether it's a basal or non-basal. So we probably would be prescribing capecitabine to all of our patients with residual disease after NACT. Next slide. Now coming to the Keynote 522 trial, which sir had just mentioned, if we see the event-free survival by patient who had a PAT-CR versus who did not have. So in the Pembro arm, again, patient who had a PAT-CR, excellent event-free survival at the end of 3 years, 94.4 versus 92.5. So both of these arms are doing pretty good. While in the patient who did not have a PAT-CR, here, this is the higher risk group, which was taken in the Olympia trial also. So in this subgroup, 67.4% is the event-free survival at the end of 3 years versus 56.8%, which was again statistically significant. So Pembro definitely improves the event-free survival. Next slide. But the overall survival benefit is not yet there. Next slide. Can we move on to the next slide, please? Yeah. So there is no OS benefit yet for pembrolizumab. And the impact of post-operative pembrolizumab is under investigation in the SWOG 1418 trial. So there is no safety signals from multiple ongoing combination studies with PARP inhibitors and IO drug. And this was again a Mediola. This was a phase 1/2 basket trial of combination of olaparib and durvalumab in patient with metastatic breast cancer. So it did not show any increased toxicity with this combination. So therefore, combination is feasible, although not yet approved, because we don't have a large data of combination of PARP inhibitors and IO. And I don't know what would be the financial toxicity in our country. Next slide. So in the ER positive subgroup, the story gets even more complicated with the the abemaciclib coming into the picture. Next slide. So yes, we all know that abemaciclib plus endocrine therapy, when compared to endocrine therapy alone in high risk hormone receptor positive HER2 negative breast cancer patients, improves the distance relapse-free survival with a hazard ratio of 0.687 and a 3-year DRFS distance relapse-free survival of 90.3 versus 86.1%. So there is an absolute difference in around 4.2% at 3 years in the DRFS rates when abemaciclib is used. Next slide. But as we discussed, that only around 18% of the patients were hormone receptor positive in the Olympia trial. And so, minority of patients were ER positive on the Olympia, but they had a clear-cut benefited The population overlaps with the monarchy, and with abemaciclib, we don't have an overall survival benefit yet. And it's very difficult to combine these two because they both have an overlapping myelosuppression. The monarchy allowed enrollment within 16 months after surgery, and serial use could be considered, although yet not approved. Next slide. So this is, the recommendations by Mr. Mark Robson from the Memorial Sloan Kettering Center in New York. Next slide. So these are his conclusion regarding this Olympia data. So Olympia is clearly a practice-changing trial, and olaparib should be offered to patients meeting the entry criteria for the study. And in triple-negative breast cancer patients who do not achieve a PAT-CR after neoadjuvant chemotherapy, he would definitely favor olaparib over capecitabine. The possible exception is if they are very insensitive to platinum. And it would not delay olaparib until after capecitabine, and safety of combination is still unclear. In the triple-negative breast cancer patient receiving neoadjuvant pembrolizumab, as per the keynote 522, he would still favor using both agents post-operatively in non-PAT-CR patient if possible, pending the results of SWOG 1418. And if forced to choose, he would still favor olaparib. An ER-positive patient would favor sequential use of olaparib for 1 year and abemaciclib for 2 years for particularly high-risk patient. And if forced to choose, he would prefer olaparib. And genetic testing should be liberalized for women who meet Olympia entry criteria, but detection rates in women over 50 to 60 who do not meet NCCN criteria is actually very low, because we have seen the median age in both these studies were 42 and around 42 years. So remember to test appropriate ER patient, that is especially young patient in male breast cancer and patients who have a strong family history. Next slide. So for the time being, when we have further data, this is the algorithm. And the high risk HER2 negative early breast cancer who are triple negative, we see whether they are BRCA mutated. And if we have, we can do, then we prescribe the adjuvant olaparib for 1 year. And if they're BRCA wild type, then adjuvant pembro for up to 14 cycles if they had received a pre-op pembrolizumab. And if not, then you can have adjuvant capecitabine if neoadjuvant chemotherapy had been given, and this is non-PAT-CR. So in hormone receptor positive HER2 negative BRCA mutated, again adjuvant olaparib for 1 year plus endocrine therapy, or you can do sequential, but I'm not sure how many of us would be choosing that. There's no right answers right now, but we have overall survival data for olaparib, while the same is not there for abemaciclib. So in BRCA wild type, definitely adjuvant abemaciclib, our job is very much easy. Adjuvant abemaciclib for 2 years with endocrine therapy would be our choice. So that's all I have. Next slide. So thank you, and over to the organizers.
Thank you, Dr. Priyanshu, for the talk. And I think in the end, we could answer all these questions. Do we need to change it from pembro to olaparib? Yes, the answers are still need to be, the questions are still need to be answered correctly, but the SWOG trial we should wait for. Is there a benefit with the change over to olaparib or continuation of pembrolizumab? See, but definitely triple negative breast cancer, if there is a PAT-CR, that is the way to, I mean, that is the thing to achieve. Otherwise, if you're not achieving PAT-CR, the disease tend to relapse, and the relapses can be very quick and dangerous. I think that's all for today. So if there are any questions, we will be discussing. If there are no questions, we would like to wrap up today's session. So I thank all the faculty and all the sponsors along with my team for today's session, and will be joining tomorrow for the management of early or resectable lung cancer management. Thank you, everyone, and good night.
Thank you, sir, and good night.
Thank you.
Support team, please close the meeting.